Hey everyone, my name is William Chong. I'm a third year Med Peds resident. And this is our first ever ITE ITE Pediatrics review. And so today we'll be covering like all the general Peds topics. So preventive Peds, newborn and NICU stuff, adolescent, genetics, child abuse, and emergency medicine. And so this is a super informal session. Basically, it's all just kind of the highlights of what's covered in med study. So there's also a lot of things that we really don't have time to get into detail, and a lot of things that will be covered in the next review sessions, which will be over like the subspecialty stuff. If there's any questions or any mistakes with some of these slides, just please let me know. This is kind of like the first time it's put together, so as we work through it in subsequent years, we'll get some things fixed and more illustrations in there. But this is kind of like the rough rundown for our first session. So here we go. So our first topic is preventive pediatrics. So growth, this is of course something that we look in our well-child checks very closely. I think the big picture things here is that when we're looking at a child's growth, we don't want to focus on one point or just one percentile. We want to look at a trend or a pattern overall and see where they are in the growth curve, if they're sticking to their own growth curves or not. So a lot of the questions that we get is for their expected height as they get older. And so for girls and boys, we can have the calculations for mid-parental height. So it's just, essentially it's an average of the mom and dad's height, and then you add or subtract a few inches. So I actually have a little bit of a dirty mnemonic to remember this, and so that's why I can share this here, because I can't put it in my slides or sent out. So the way I remember it is that for boys, it's the same. The only difference is that you add 5 inches to it because boys have an extra 5 inches on their body. That's how I remember it. And then you just subtract the girls. And then you want to know the difference between constitutional growth delay and genetic short stature. So constitutional growth delay, there's those late bloomers. And so as a teenager, they're really short. They're not quite as tall as their peers. And their bone age is actually delayed to their chronological age. And so I remember that because their bone age has some catching up to do to meet their actual chronological age. And so with their growth curve, you'll see them, they'll actually have some catch up later on, where they were kind of in the 5th percentile, they might jump up to the 25th or 50th percentile. For genetic short stature, both parents are short, and their plots are going to be parallel to the growth curve like here, so they're just going to be on their own growth curve that's kind of lower on like the 5th or 3rd percentile. So these are some fun growth stats, not that fun. You just kind of want to know these, and you kind of know through experience. I don't really have a good way of remembering it, and my mnemonic for this is a little bit stupid, but if you can just remember the doubles and triples, and the number 4, and like 12 or 13 for the doubles and the triples, then you know the birth weight doubles at the 4 months, triples at the 12 months, the length doubles at the 4 years, and then triples at the 13 years. Sorry, that's the best I got. But birth weight regains at 10 to 14 days, that one's an easy one because we always know at our 14-day well-child to look at that compared to birth weight, make sure that they are catching up to that. And then the rest of the stats, probably not like super high yield for testing, but it's there. Okay, failure to thrive, so this is defined as the weight less than the 3rd percentile or weight for height less than the 5th percentile, or downward crossing of 2 major percentile or inadequate gains from 0 to 6 months. So our organic failure to thrive stuff, these are the rare ones. So these are the ones you want to think of medical conditions that are causing it. So again, really simple, just break it down. Too much caloric losses or increased caloric requirements. So you have GI malabsorption, endocrine disease, some renal disorders, you're going to be losing it. So it's spilling from the kidneys. There's hormonal imbalances that causes inefficient use of the calories, or there's too much caloric requirements. A cardiopulmonary disease, when you have those cyanotic babies with the heart conditions, they need more calories, so that's why they're not growing properly, because they're not getting enough intake. Hyperthyroidism with an increased metabolism, recurrent infections. And then we're getting into more of the other causes, the inorganic causes, the psychosocial behavioral feeding problems, which are more common. And basically, parents just aren't feeding enough. So you want to get a good dietary history. You want to look for any signs of neglect. So you want to look for any gaze disturbances in a kid, developmental issues. You want to watch for parental interactions and any psychosocial failure to thrive. And also get some lab studies as well. So these kiddos need hospitalization for any abuse or neglect, parental substance abuse, high-risk environments, severe malnutrition, medical instability, or if they even failed outpatient management, they need to be inpatient for feeding observation. Developmental delay. So these are things that you want to be concerned about. I don't have a slide with all the milestones here because I just felt that it's kind of tedious just to memorize all the milestones, and we kind of know most of the big ones, and it's not the most high yield for testing topics at this point. But I think we should probably be aware of like the red flag signs when they haven't met this milestones and when it needs to be worked up. And that's going to be your head control, not done by 3 months, fisting beyond 3 or 4 months, primitive reflexes like the rootings, stepping, sucking, grasp, or moro. And if you see that past 6 months, that's an issue. And then as far as like language development, if you have less than 50 words or no 2-word phrases by 2, echolalia, or the repetition of words and sounds beyond 30 months is also of concern. So you want to review the newborn screens on these kids, check lead levels, thyroid studies. Intellectual disability is going to be an IQ less than 70, and 4 to 8% of these have chromosomal abnormalities. So common causes are, of course, genetic syndromes, trisomies, CNS insults in utero, and metabolic disorders. And so we manage these with CMA genetic studies. That's usually a pretty common workup. And then brain MRI, EEG, metabolic screen if indicated as well. Okay, so moving on to the screening stuff. Now some of these, I'm just going off of what is in med study, and I try to kind of keep current with a lot of AAP recommendations. Now a lot of these things are not what we usually do in clinic routinely, but these are probably what they would test over and expect you to answer. So as far as newborn screen, you want to include that first one 24 hours, after 24 hours and after 24 hours of feeding. As far as vision, you want to do a reflex at birth and then tracking by 2 months. The corneal red light reflex, uncover and uncover test when they're a toddler or preschool age. And then refer any school-age children with any difference in visual acuity greater than 1 line. Your hearing screen, so this is an important one. You want to get it by 3 months. That's when it's recommended. You can either do the ABR or the OAE. All right. So this screening is more into adolescent things, and so for overweight kids, this is your BMI in the 85th to 95th percentile. Obesity is going to be considered BMI in the 95th percentile. Alongside of that, you want to also ask them about screen time, and it's no more than 2 hours per day for kids greater than 2, and you don't count like the time they spend on a computer for homework stuff. And then kids less than 2, absolutely no screen time at all. Hypertension routine screen will start at 3 years of age. So your stage 1 hypertension is going to be your systolic or diastolic 90 to 95th percentile plus 5 millimeters mercury. Your stage 2 is going to be systolic or diastolic greater than 95 plus 5 millimeters mercury. So cholesterol screen, I think this one's kind of controversial, and we probably don't follow this one as much, but we screen at age 9 to 11 and again at 17 to 21. If the non-HDL cholesterol, which is the bad part, is greater than 145, or the HDL, the good cholesterol, is less than 40, then you want to get 2 fasting lipid panels and then average them and see what that is. You might consider more additional screening than those 2 times if there's strong family history of hyperlipidemia or heart disease or other risk factors in the kid. Lead screening. So a lot of times the lead issues are kind of picked up from our questionnaires or just incidentally found on screening. They usually don't present with any symptoms, but when you're getting blood, the at-risk levels are going to be greater than 5 micrograms per deciliter. And you want to, if it's as high as greater than 45, then you want to consider chelation therapy because they're at risk of developmental symptoms from that. So the risk factors for that is going to be a house built before 1950, sibling with elevated lead levels, household folk remedies with lead, immigration from a country with high lead levels. Iron deficiency screening, so I actually looked this one up, and this one's one of those really controversial ones as well. So hemoglobin or hematocrit routine screening starts at 12 months, and you might want to do frequent testing for higher risk groups. The reason why this one's controversial is because they say that the hemoglobin and hematocrit don't really correlate well with iron levels anyway, so you might not be picking up iron deficiency. So you want to think about it in premature kiddos, those who have extended breastfeeding. Early intro to cow's milk is a big one. Poverty, limited food access, vegan diet, malabsorption. And your teenagers, especially in your females with heavy menstrual periods.
I was going to add something too.
Go ahead.
For any of like our interns who haven't taken step 3, for some reason step 3 like loves lead, and so actually one of my like cases on the day was lead, and so what they really like for you to pick up on, like Will was saying, the time that you should be like screening for it and be able to know like the symptoms that you might pick up on it, such as anemia or such as like some cognitive like issues. But know that, and I saw sometimes like 40 for whenever you would actually like treat. So you have to get pretty high. And then to like iron deficiency, just knowing too as well within our clinics, like especially if they're drinking even at past like 12 months, if they're drinking like greater than like 32 ounces of milk like per day.
Thank you.
Oh yeah.
Okay, more screening stuff. So autism screening, I think we're pretty familiar because we follow this in our clinic. So our MCHAT, that's a questionnaire that we're gonna do for autism, and we do it at 18 and 24-month visits, or anytime there's any parental concerns, that being if they have any deficits in the lack of social smile by 6 months, not making eye contact, if they're babbling, not babbling, or making gestures at 12 months, if there's any delay in language, or not doing the pretend play or symbolic play by 18 months. Those are sort of red flags to look out. You want to screen for that. Dental screening. So they should see a dentist either by 6 months after their first tooth comes up or by 1 year of age. And they should brush twice per day before native toothpaste when they have a tooth. The TB screen, that TSD is actually, that's not T-spot, that's the tuberculosis skin test, and it's for children less than 5 years. If they have latent TB, it's better to do the IGRA testing, and as that's better for children greater than 5 years or if they've gone to BCG vaccine before. Oh, moving on to nutrition. Breastfeeding, we recommend for at least 4 to 6 months. And it is pretty common for those exclusively fed breastfed infants to lose up to 10% of their birth weight in the first 10 to 14 days. So there's many benefits of breastfeeding. The ones that I'm kind of just talking about is a reduced rate of sepsis, UTIs, recurrent otitis media, and neck. So as far as feeds, the infant feeds about every 2 to 3 ounces every 2 to 3 hours as the newborn. You want to avoid bottle propping and introduce the cup at 7 months, wean the bottle around 9 to 12 months. If there's any concern for lactose intolerance or galactosemia, then you're going to do a soy formula. And if there's any problems with milk protein allergy, you're going to do the hydrolyzed formula. That's already all broken down, so they don't have problems with that. All right. So more nutrition stuff. We want to supplement with vitamin D, 400 units, if breastfeeding or getting less than 33 ounces of formula. So I feel like we're good about doing it for breastfeeding, but I'm not really. I feel like we just kind of glaze over that if they're formula feeding and just assuming they're getting enough vitamin D. I actually haven't really seen like a lot of supplementation, but that's what I found in that study.
So the question, the way they're going to ask the question is, the baby's is both breastfed and formula fed. When can you stop the vitamin D supplementation? And so the baby has to be taking at least 33 ounces of formula a day before you can stop the supplemental vitamin D. So, yeah.
Yeah, that's why like a lot of, that's why we should just be so shouldn't we just supplement like all our little infants until they're like 4 months, because they're usually not taking that much.
Yeah, my community clinic provider checks on that, but I feel like a lot of them have to drop the samples and stuff too.
Yeah. Yeah,
What age
mostly
are
on.
they supposed to start at 4 months?
Like, from the beginning.
Oh,
Mhm.
And then the iron is at 4 to 6 months.
that's what I meant.
Oh,
They
yeah,
start
yeah, yeah.
iron at 4 to 6 months.
Right. So yeah, the iron, you want to do that then, because at first when they're getting solid foods, that's when you introduce solid foods at first, but they're probably not getting a lot of enough nutritional iron in. So when they start getting those solid foods, you want to give them cereal that's iron rich or fortified. And then also supplementing for breastfed preterm infants with very low birth weights. So solid foods, like we just mentioned, 4 to 6 months, and you want to introduce them one at a time, just to gradually wean them in, and also you can observe them when they get a new food to see if they have any allergic reactions or intolerance to that food. Cow's milk, just like Leanna said, you want to delay that until 12 months because of the risk of iron deficiency anemia. You want to encourage self-feeding and avoid any foods of aspiration risk, like popcorn, nuts, whole grapes, or hot dogs. You want to cut those off for the kiddo. Okay, some other well-chopped topics. So back to sleep, this is going to reduce the risk of SIDS and sudden infant death. There's no need for nighttime feedings after 6 months. You can let them sleep during the night. Colic is this idiopathic crying, which we don't really understand. It's usually occurring more than 3 hours and occurring for more than 3 days for at least 3 weeks, and it's very common. And what you want to do for that is try soothing tactics. A lot of people think it's related to like the feedings, and they might try switching formulas, but there's really no evidence for this in the absence of any GI problems or intolerance. Don't beat your kids. Wear a bicycle helmet.
What age is colic the most? Like, when does it start?
It usually peaks like pretty much between 4 to 8 weeks. Usually in that period, like usually up before the 2-month visit is when those parents are going to come in talking about colic. And a lot of those babies are just gassy at baseline.
And then other safety things and well-shot topics. The AAP recommendation is no guns in the house. So this was actually a question from TPS Pediatrics Jeopardy that I missed. So, and the right answer is no guns in the house. But they say if you do keep the guns, then what you should do is keep the guns unloaded and the ammo separately locked away in different containers. For a hot water heater, the temperature should be 120 degrees Fahrenheit or less. And then car seat AAP recommendations, and this one just changed recently as of last year. So infant toddlers in rear-facing car seat and the back seat until they exceed the size limit. Toddlers preschoolers in their forward-facing seat until exceeding the size limit. And school-age children booster seat until 4 feet 9 inches tall, and then back seat until 13 years of age. All right, vaccines. So this is kind of a hard one to teach. We should probably already know this kind of just with our wild child checks through experience. But I'll try to go through this, and then we'll refer back to this chart and kind of talk about some of the exceptions. I think a lot of the exceptions and the catch-up immunizations, those are probably one of the more highly tested material. But basically the one vaccine that you get at birth is going to be the Hep B. And you can delay this vaccine until birth weight is greater than 2 kilograms. So if mom is Hep B positive, you want to give the Hep B immunoglobulin and the Hep B vaccine. Now at 2 months and 4 months, this is when we get our next shots. And so I like to remember these 6 together. It's so DTaP, IPV, your inactivated polio, PCV13, which is your pneumococcal, Hep B, Haemophilus influenza type B, and the rotavirus. The one I started Hep B because the Hep B, you give it at 2 months, and then you don't have to give it at 4 months if you've already given it at that time. And then the rotavirus also has a special condition that you can't give it if it's been more than 15 months. And you also have to complete the whole series by 8 months. So those are some special cases. But I like to remember those 6 for like 2 2 months, 4 months, and 6 months. And then starting at the 6-month mark, it's just like we said, there was 6, but then we get the second, we get influenza, and you want to give 2 shots for that first time. At 12 to 15 months, we're giving more of the live attenuated vaccines, so MMR, varicella, Hep A, and then we're also going to give the 4th DTaP. Our second Hep A has to be 6 months after the first. It's one of our special conditions for that. At the 4 to 6 year mark, we have the 5th DTaP, another IPV, the second MMR, and second varicella. And at 11 and 12, we do Tdap, not the DTaP, but a Tdap. And then we do that one time, and then after every 10 years, we can do the TD. Also, at 11 years, we can give the meningococcal vaccine and a second meningococcal booster at 16. And also, we can start introducing HPV starting at this age. Okay, so I just put this here. This is our trusty vaccine schedule guide that we always like to refer to in clinic, just for your reference. And then I think we talked about a few of these special cases. So we don't want to do any live attenuated influenza less than 2 years old if they have asthma, immunocompromised state, or living with someone with severe immunocompromise. Anaphylaxis is the main absolute contraindication for any vaccine. So live vaccines are contraindicated in immunodeficiency, except where HIV with CD4 are greater than 15%. In pregnancy, you can give the Tdap and the flu, but no live vaccines. And then the DTaP has another contraindication, and that one's going to be history of encephalopathy within 7 days of getting it. Same thing, again, if there's anaphylaxis or any history of progressive neurological disorder. Okay, so this last one is kind of like the special cases for any catch-up vaccines. So a really good question is that you have 8-year-old, what vaccines can they not get if they haven't started their series? So at this point, you can't give HIP, you can't give rotavirus, because that one you had to give before 15 weeks to start and finish by 8 months, and you can't give DTaP after age 7, because you want to do Tdap instead. Okay. All right, so we're all done with the preventive pediatrics section. There's probably a good number of topics missing, and they might be, there's some overlap with other sections like adolescence, and some of the other order screening things. Any questions so far? Looks like we're making pretty good time. So newborn and neonatology. A big thing that we want to know about is GBS prophylaxis and management. So GBS screening is universal. All moms need to get it at 35 to their 37 weeks of gestational age. Our intrapartum antibiotic prophylaxis is, we need to do it for these indications, and we want to know these really well. So obviously, if you had an infant who had GBS disease in the past, if mom had GBS in the urine during pregnancy, if the GBS testing came back positive, or if it's unknown status with other risk factors like fever, premature rupture membranes, preterm delivery, then there's also high risk for that. And also the intrapartum NAAT GBS positive. So as far as the prophylaxis, our ideal treatment is going to be penicillin G 5 million units IV one time. And then you're going to give 2.5 to 3 million units IV every 4 hours until delivery. Ampicillin is okay, that counts too, but Clinda or Vanc isn't as good, but you would do that if they are penicillin allergic. So this is a little bit more about GBS disease. So early onset GBS disease is going to be before 7 days of life, late onset as after 7 days. So these are the special conditions for management of the baby. So if you gave the prophylaxis and baby has signs of sepsis, you want to do that whole workup and start treatment. Now, if you gave prophylaxis and baby has some risk factors like preterm or membrane rupture that was prolonged as in greater than 18 hours, then you can do a limited workup with the CBC and blood culture. If you gave the prophylaxis in babies greater than 37 weeks, you need to know, was this adequate treatment? meaning that was it the right antibiotics, was it your penicillin, and also was this more than 4 hours prior to delivery, because you need that for it to count. Okay. If you did not meet those conditions, you want to observe them for the full 48 hours in nursery. Henry, I'm so glad you're here. You can double check my neonatology slides.
And these are all the questions that your chiefs will be asking as you're attending at LBJ and on Well Baby.
Okay, NRP, I feel like this is probably less likely to be tested, but it was part of med study, and I felt like I might as well include it anyway. And it's good for y'all to know because you'll have to know NRP cold when you're on NICU or attending these deliveries. So your APGARs, these are going to be just an assessment of how baby's doing right after they're born. You're going to get them at 1 minute, 5 minutes, and you're going to keep getting them if they're still low. So with resuscitation, you cannot resuscitate a cold baby. That's one of the most important things from the very beginning you want to think about. So you want to turn on that heater, dry the baby, and place a hat on their head because that's where most of their heat loss is going to be from. If they have low O2 sats, you want to refer to that pre-ductal targets for O2 saturations, and you want to give blow by oxygen if they're not meeting those targets. And you want to also do it if they have cyanosis, with any concerned cyanosis, or if their heart rate's less than 100. If they're apneic, heart rate less than 100, at this point you want to do positive ventilation. So the PPV is going to help at this point. Your heart rate increase is going to be the best indication that you're doing good ventilation. And if you remember from your NRP training, you want to do Mr. SOVA, make sure that you're doing good ventilation before proceeding to the next step. Because the next step, if they're not ventilating well, or their heart rate drops below 60, at that point they need chest compressions. And when you're at this step, you already should secure an airway with intubation, be turning that oxygen to 100%. Okay. Now, in moms, this is of narcotic abuse, you may even consider naloxone for a baby. All right. So some more well baby and NICU things. Some pretty commonly tested things is going to be about that swelling on the head. So to cap it, the easier to remember this is cap. So you'll see it kind of crossing the suture lines. Think of it as just a cap over the head. And so you have blood and edema in the soft tissue of the skull crossing suture lines. And that's going to be very superficial. Your cephalohematoma is going to be on one side, so it doesn't cross the suture lines, and it's usually over the parietal bones. And this one is a collection of blood beneath the periosteum. And it feels a little bit squishier and tougher because there's some underneath more layers, so it feels a little bit more like pitting edema. Your subgleal hemorrhage, this is the one you really want to look out for because it could be an emergency. So you have bleeding beneath the scalp, alpha-neurotica, and it's firm with fluctuance over the scalp. And this one, you can have like a lot of risk of hemorrhage with extension all the way to the back of the neck. And so I have these diagrams here kind of outline the three of them. This one being caput, this one is the cephalohematoma, and this one is our serious subgaleal hemorrhage. All right, so other newborn disorders we look out for, we're of course doing that red reflex on our babies, looking for any signs of leukochoria. Leukochoria being a white pupillary reflex, and it's associated with chorioretinitis, retinopathy of prematurity, or retinoblastoma. Conjunctivitis is an issue in kiddos too. In the first 24 hours, we want to think about chemical conjunctivitis. Around 2 to 5 days of life with copious discharge, that's going to be gonorrhea. Just like with STDs, we think of gonorrhea being a lot of discharge, same thing with the conjunctivitis. And then later on, around the 5 to 14 day mark, is going to be chlamydia, which is going to be your most common bacterial cause of conjunctivitis. Thyroglossal duct cyst, you're going to see it over the front and the midline of the neck, and then if you have babies swallow and watch, you can see that the mass moves with swallowing and with tongue protrusion as well. So if you have a very complicated delivery for babies, sometimes they'll have some shoulder dystocia, which is going to cause the Erb's Duchenne palsy. So they present with the arm held to one side and internally rotated with that waiter's tip kind of presentation. The clumpy palsy, this is going to be your ulnar nerve deficit, and they have the claw hand. Sometimes you see Horner syndrome as well with ptosis, meiosis, and anhydrosis. Another thing that you see with difficult deliveries is going to be your clavicle fracture. And you'll notice that there might be some crepitus or some crackles or gas-like feeling when you palpate around the clavicles and upper chest area. All right, more disorders. So in your abdominal exam, if you see like a midline gap between the abdominal rectus muscles, that's going to be diastasis recti. The omphalocele is going to be abdominal contents that are protruding, and these are going to be covered by a visceral layer, and you'll see it coming through a periumbilical defect. Your gastroschisis is your other one with protrusion of abdominal contents, but these will not be covered, and usually these are going to be to like one side of the abdominal wall defect. Prune belly is where you have an absence of the anterior wall muscles, and you also see a lot of genitourinary problems, one of them being cryptorchidism. On that GU exam, if you have a stretched penile length less than 2.5 centimeters, that's abnormal, and you want to do endocrine workup for that. And any failure to pass the meconium in 48 hours is concerning for Hirschsprung's. Hip dysplasia is common in females and with breech presentations. When you do the ortolani and Barlow maneuver, what you're trying to do is you're trying, with the ortolani, you're testing for reduction, and Barlow, you're trying to dislocate it. And so if you feel, you might feel a few clicks and that's normal, but if you feel like an actual clump, then that suggests hip dysplasia. Another sign of it too is looking at discrepancies in the leg lengths or asymmetry in the gluteal folds as well.
For the meconium too, they also like to test a lot with CF too as well.
Yeah, right. Yeah, that's a good point. And yeah, we have CF on another session on respiratory where we'll talk more about meconium ileus. Is that? Okay, there we go. So the neonatal prophylaxis that we do for our newborns, so we want to get erythromycin, the eye ointment within 1 hour, and then vitamin K 1 milligram intramuscular a few hours before birth, and this is going to prevent us against hemorrhagic disease in the newborn. Circumcision is not recommended routinely, but we do talk to parents about the benefits which outweighs the risk. Benefits being decreased UTIs in the first year of life and decreased transmission of HIV and other STDs.
What's the erythromycin treating? That's the question that they're going to be making sure you guys understand. Like, why do you give erythromycin ointment in the eyeballs?
Or chlamydia.
Yeah. The other way that I've seen questions too, like what Dakota may be getting at, is like even if you, like, let's say the baby comes in, like Flo was saying, it was like a home delivery, it's at like 2 weeks of life now, it has kind of this watery, kind of purulent discharge. They may be getting at more of like a chlamydia infection, which you can actually treat with erythromycin. Like ointment alone, you have to do it orally because you're trying to prevent against the pneumonia too as well. So is that kind of what you're getting at?
Yeah.
All right, other screening things are glucose checks. So we don't do glucose checks for every baby, but the ones we want to do it for, we're concerned about hypoglycemia, is going to be on LGA babies, SGA babies, prematurity, low birth weight less than 2,500 grams, infant and diabetic mothers, obviously high risk of that, polycythemia, hypothermia, acute illness, or if they're symptomatic. Those are the reasons we want to check the glucose for. So we want to get the blood type in the baby for any mothers who are blood type O or who are Rh negative, because these are the babies at risk for ABO incompatibility or Rh isoimmune hemolytic disease. Hearing screen, like we mentioned, we do this for all neonates by 3 months of age, and our congenital heart screen, we get pre-ductal and post-ductal oxygen sats at the after 24 hours, because we want to see what it is after that PDA is closed. So 24 to 48 hours after a day, but before discharge from the hospital. Okay, infant and diabetic mom. So maternal hyperglycemia leads to fetal hyperglycemia and hyperinsulinemia, and this leads to a lot of complications. So our macrosomia is We have a big baby, and this can cause a lot of birth trauma with like their shoulder dystocia and those nerve palsies that we talked about. Because we gave baby a lot of sugar, baby's making a lot of insulin, but then once baby's born, the insulin's there, but the sugar's not there, so now baby's going to be hypoglycemic because of the high insulin. Along with the high insulin, we have a lot of electrolyte abnormalities as well, including hypocalcemia, hypophosphatemia, and hypomagnesemia. So all those electrolytes are going to be low because the insulin's shunting all those things into the cell. We also have increased risk of hyperbilirubinemia. And then with that extra glucose load and bringing it into the cells, you're actually building up a lot of glycogen in the heart, causing a bit of a hypertrophic cardiomyopathy. Not like the HOCM that we think about. This is more a transient one where we have a thickening of the septum. And then we also have respiratory distress syndrome because we have inhibition of the surfactant production in these babies. Other congenital anomalies that we see with IBM is going to be the VSD, neural tube defects, GI atresias, sinus inversus, urinary tract abnormalities, spinal agenesis, caudal regression syndrome, and then small left colon. Okay, so we're getting into the respiratory diseases. RDS, this one is going to be, you're going to see more and more of it as you're getting into more premature infants. There's a lack of surfactant due to the prematurity, and this causes collapse of the alveoli in the airway. So what we do for this is we gave antenatal corticosteroids, betamethasone, for pregnant women around 23 all the way to 34 weeks of age at risk for preterm labor. And then once baby's born, we give intratracheal surfactant 30 to 60 minutes after delivery. We also give prophylactic surfactant. They don't have respiratory distress, but they are less than 28 weeks because they need it. The other really common that you guys are going to see a lot in newborn nursery is going to be TTN, the transient tachypnea newborn. So we classically see this in late preterm and babies delivered through C-section. Basically, there's just some extra fluid left in the lung, and that's causing their respiratory distress. So they just need some extra time to clear the fluid. It should be reabsorbed, or they're going to cough it out. And this usually resolves in 12 to 24 hours. Other respiratory diseases, so you can have the persistent pulmonary hypertension in newborn with elevated pulmonary vascular pressures. This will cause the right to left shunting and hypoxemia. The treatment for this is supportive. So in our really premature infants, less than 32 weeks, we also think about apneas and apnea of prematurity. Causes are usually sleep-associated, hypoxemia, and gastroesophageal reflux. And we usually manage the apnea of prematurity with tactile stimulation, CPAP, or caffeine. Meconium aspiration syndrome, we have these babies in respiratory distress after delivery, and usually you see the fluids from mom meconium tinge. There's chest x-ray with patchy infiltrates, and pneumothorax is also common in these babies.
Like, I feel like the way that I've seen the meconium aspiration syndrome tested is mainly harkening back to like old recommendations, making sure that people understand the updates, even though I've never heard them. But like they'll say, you know, the baby is born with like meconium staining and is very vigorous and is doing well. And it just wants you to make sure that you just say like normal like neonatal resuscitation. Like you don't have to do the deep suctioning or intubating, and because that's all old. So I don't know. That's what I've seen.
Remember, pneumothorax is also another common respiratory disease, and a lot of them are not big enough to cause any respiratory distress and resolve on their own. You want to look out for, in emergency cases, tension pneumothorax. In this case, if you have heart shifting to the side that doesn't have the normal pneumothorax, and the diaphragm may be displaced downward. So these are emergencies, and you need to manage them with a needle decompression, and you'll stick the needle in the second intraclavicular space, mid-clavicular, or fifth space, mid-axillary. Going on to the GI diseases, the newborn, we have meconium plugs. So when there's low water content in the baby's stool, this can cause obstruction, ulceration, and perforation. And so like we mentioned before, we see this a lot in CF, hypothyroidism, and Hirschsprung disease. And you want to give an enema to loosen the plug and loosen the obstruction. Meconium ileus, this is impacted meconium that causes some obstruction, and you want to look out for meconium peritonitis on the KUB or CT. CT can show intra-abdominal calcifications with this condition. You want to give trizoate sodium enemas and surgery if it's complicated with intestinal intrusures, volvulus, or perforation. All right. So a big thing that you don't want to miss as far as GI diseases is going to be neck. That's going to be necrotizing enterocolitis. This is the most common intestinal emergency in preterms, and it's occurring in the first 2 weeks of life usually. So you can start off with some abdominal distension, some bloody stools, maybe even just some mild feeding intolerance, but this can lead to some very serious life-threatening conditions, including sepsis, perforation, bilious vomiting. So you can diagnose this on KUB, and so I picked out a really remarkable one. So when you show, I don't think I've ever seen one anywhere close to that. Usually it's more subtle than that, but just to illustrate the findings, because you really want to know what it looks like. Your pneumatosis intestinalis is going to be that air that you kind of see in the bowel wall. All right. Another thing that's also pathognomonic besides the pneumatosis is going to be air in the portal system, in the hepatic portal system. So you see where the liver is, you can see those, the portal vasculature actually has some air in it from the air that's in the bowel. So we want to manage your bowel rest. So do not feed these babies. They should be on TPN. We can give them NG decompression IV fluids, and they need broad spectrum antibiotics with Vanc, Gen, Flagyl, Zocin, or Zocin. So in a lot of these cases, you can manage medically, but if it's severe where you're concerned that the bowel is dead, probably like this baby, you would need surgery, consult for possible exploratory laparotomy and resection of the necrotic bowel and ostomy placement. Hyperbilirubinemia. All right, so we see this a lot. Our normal physiologic jaundice, this is going to be peaking at 3 to 4 days, and this is just because the enzyme is kind of a little lazy. So that UGT enzyme that conjugates the bilirubin isn't working so well just yet. At the same time, our newborns have increased turnover of blood cells, and so that's why there's also more bilirubin around. So the thing to remember is that hyperbilirubinemia in the first 24 hours of life is pathological, and you want to work it up because it could be hemolysis, sepsis, and congenital infections. Other risk factors for hyperbilirubinemia is going to be your prematurity, another sibling who required phototherapy, any delay in bowel movements, cephalohematoma, birth trauma, East Asian ethnicity, or exclusive breastfeeding with greater than 10% weight loss. So we're checking these bilies to make sure they don't get too high to a dangerous level that we need to treat. So we'll measure a transcutaneous bili, but we need to confirm these with the serum bilies because the transcutaneous one, there can be a lot of inaccuracies, especially if they got phototherapy before, because if they did, then those wouldn't be accurate. So with our bilirubin levels, we need to, of course, input them in BiliTool, which is based off this Butani normogram, this is what it looks like. And you kind of risk stratify them to decide how often you need to follow the bilirubin level and when you need to do phototherapy or exchange transfusion. Okay, so other causes of hyperbilirubinemia, we have breastfeeding jaundice. So this occurs in the first week and there's inadequate intake. So you might get a decrease in wet diapers or just a history that they're just not feeding nearly enough. Or clinical signs of dehydration. So what you need to do is increase the feedings. If they're breastfeeding, they might benefit from a lactation consult because they could just be from poor technique, or they might just need a supplemented formula for a while just so that the baby gets enough intake. Your breast milk jaundice, this one is occurring in the second week of life, and it's probably caused by something in the breast milk, but we don't really know exactly what it is. For these, you just can continue breastfeeding and they will resolve on their own. No real interventions need to be done. Your Gilbert syndrome is going to be benign decrease in the functioning of that enzyme and conjugation, and there's nothing to do for that as well. Crigler-Najjar is kind of like the bad version of that disease where you have severe enzymatic deficiency of UGT. And so you want to treat with phenobarb, which induces the enzyme production. Kernicterus, this is the fear complication when our bilirubin gets too high, and this is the reason why we treat it before it gets too high. So this is when the unconjugated bili gets deposited in two parts of the brain, including the basal ganglia, hippocampus, and the cranial nerve nuclei. And this can cause poor feeding, stupor, seizures, or hypotonia early on and hypertonia later on.
Actually, kernicterus is a chronic condition. It's actually, we have hyperbilirubinemia. We know the definition of hyperbilirubinemia. Then we have severe hyperbilirubinemia if it's above 25. And then we have BIND, B-I-N-D. That's bilirubin-induced neuro dysfunction. That's when you have high risk, and kernicterus is the condition, the chronic problem. I don't know, by definition, right? I don't know if it's actually the deposition of that. You may have the deposition with the bind. Kernicterus is actually the disease, the condition, the chronic problems.
Okay. I'll clarify that, yeah. Thank you, Henry. Okay. All right, so that's it for neonatology. So we have adolescent, just have a few more sections. Let's see where we are. Do y'all want a break?
I think we're good.
Or we're good? Okay, we keep coming.
Power
back.
through.
Okay, power through.
You got it.
Yeah.
Doing great.
So adolescent, normal pubertal development is, remember our first sign of female puberty is going to be breast development or dilarchy. Our first sign of male puberty is going to be testicular enlargement. The female mean age of puberty is going to be at 10 years of age, and then males are a little late, a little delayed. They're going to have their puberty starting usually around 11.6 years. Keep in mind that there's a range of puberty. So African Americans can experience puberty about 6 months earlier than their mean counterparts. And the mean age of menarche and girls is going to be 12 years. So eating disorders. The first one we're going to talk about is anorexia nervosa. So this is going to be a restriction of caloric intake, leading to significantly low body weight with fear of weight gain and disturbed perception of body image. So there's a lot of complications with these, a lot of them being metabolic and with electrolyte abnormalities. So the electrolyte abnormalities we think about is going to be everything that's low. So low potassium, low sodium, low chloride with alkalosis because of the purging. There's also anemia, hypophosphatemia, hypothermia, bradycardia, and orthostatic hypotension. So we can also think of all those things low as well. Low temperature, low heart rate, low blood pressure. Complications from this, because of the nutritional deficiencies, includes osteopenia. There can be prolonged QT from the electrolyte abnormalities. And you also want to watch them for refeeding syndrome, which can cause life-threatening hypophosphatemia. Heart failure is also another complication. So you want to kind of work them up, consider a DEXA scan, vitamin D, calcium supplementation, and you want to, when you have them in a hospital, you want them to, of course, gain nutrition, but you want to wean them in slowly, gaining only 2 to 3 pounds per week to minimize that risk of refeeding syndrome. Our hospitalization criteria, if they're refusing to eat or not eating anything, anytime you have abnormal vital signs, so that hypotension, heart rate less than 50, orthostatic changes, electrolyte abnormalities, failure of outpatient treatment, any arrhythmias or suicidal ideations, that's when you need to admit your patient with anorexia to the hospital. The next eating disorder is bulimia nervosa. So this is recurrent binge eating with inappropriate compensatory mechanisms. And these patients are not not underweight, like with anorexia, they're gonna have normal to overweight BMIs. So in an exam, you might notice that they had painless parotid swelling from all the vomiting. You might see calluses on the back of their fingers because they're inducing vomiting with their fingers, and they can have soft palate petechia or loss of tooth enamel, again from that stomach acid in the mouth. So you're, again, you have like the same electrolyte abnormalities, your hypochloremic, hypokalemic, metabolic alkalosis, which you want to just think about those 4 words anytime you think about vomiting. And you can also see elevated amylase with that as well. So SSRIs is more effective in the treatment of bulimia than with anorexia. So these are sometimes used here. In females, there's a few breast disorders we should know about. There can be some asymmetry, and that's pretty common and can stick with them into adulthood. Supernumerary nipples and accessory tissues along the milk line are also common disorders. Breast cysts are the most common breast mass. You just want to follow this with serial exams. You can do an ultrasound of it just to see if there's any solid masses that would be concerning. But if you can't really tell and you're concerned about it, you can do needle aspiration for the lesions and do some cytology, but only if the fluid's bloody, because then that would be concerning. If you have cysts with complex features, as in like loculated multiple septations, then you might want to consider biopsy of those. Your fibroadenoma is your most common solid breast mass, and this is going to be firm, painless, rubbery masses. You're going to observe them when they're less than 3 centimeters, and if they're larger or persistent or suspicious lesion, consider biopsy. And then lastly, your fibrocystic changes is going to be bilateral fullness and tenderness in the upper outer quadrants. It's associated with the menses. It's a key history here. And a treatment for this is just supportive bras and NSAIDs. And I don't include breast cancer here just because it's incredibly rare and it's like less likely to be tested. So you really want to just be thinking about these with the breast masses as your common disorders. Amenorrhea. So your primary amenorrhea is when you've never had any menses and you haven't had them by the age of 15. So that's a key number here. Your secondary amenorrhea is that you had menses before, but then you lost them. You don't have them anymore. So you haven't had menses for 6 months, or you've had 3 irregular cycles before. And the most common cause, teenagers, adults, you want to think about pregnancy. So that's the first thing you want to rule out right off the bat. Now, other things you can consider is going to be your hypothalamic, your pituitary amenorrhea, where you have inhibition of GnRH. Other things can be eating disorders, stress, and this is going to be causing that functional hypothalamic amenorrhea. Common syndrome is going to be congenital lack of GnRH hormone and anosmia, that inability to smell. If you have a patient with amenorrhea and breast discharge and galactorrhea, then you want to think about a prolactinoma and consider pituitary imaging for that. So then, those are kind of the pituitary or neurological hormonal causes of amenorrhea. Getting down to the actual ovarian causes, these are more disorders of the estrogen progesterone hormone. So gonadal dysgenesis, we see these with Turner syndrome, and so that's going to be a primary amenorrhea. PCOS, congenital adrenal hyperplasia, Cushing's disease, anabolic steroid use causes an increased androgens and causes secondary amenorrhea. With PCOS, we see hyperandrogenism and abnormal menses. We also want to think of an anatomical defects as potentially causing amenorrhea, and so these could be in the biliary duct system, including imperforate hymen, vaginal atresia, or absence or malformed cervical uterus. So with an imperforate hymen, hymen, sometimes you might get the history that they've never had a period, and then they have like the cyclic pain that comes every month, and just basically they're having their period, but it's just not expelling out because the hymen is imperforate and doesn't allow passage of your menses.
And two, on those questions, that it may give you like a physical exam finding that whenever you do it, you sort of see like this bluish, like bulging mass. And then you basically just have to resolve that, and she's good.
Okay, so like we talked about, the first thing we want to work with amenorrhea is that pregnancy test. Then we can consider getting other labs. So a lot of these labs here, LH, FSH, prolactin, free testosterone, DHEA. So this is looking at a few androgens and hormones to see if there's any PCOS. TSH, screening for any thyroid disorders that could be causing amenorrhea. One way to work this up is progesterone and then estrogen challenge. So the progesterone challenge is you give progesterone and you see if you get a positive response, meaning that if that causes bleeding. So if you give the progesterone and it works, then you know that it's the progesterone that was deficient, and there's your resolution. If it doesn't work and you don't get menses, then it could be an anatomical problem, or it could be a problem with estrogen. So the next step is the estrogen challenge. So you give estrogen, see if that works. Now, if that doesn't work, then you want to think about anatomical abnormalities, get a pelvic ultrasound, and get further workup with other hormonal levels. So our treatment, OCPs are going to be for first line for a PCOS. We can give spironolactone, which is going to block a lot of the androgen effects. So we can do this if we see some hirsutism. For prolactinoma, dopamine agonists are going to be our first line of treatment. So some other menstrual disorders, dysfunctional uterine bleeding. This is going to be your cycles less than 20 days or greater than 45 days with more than 8 days of bleeding with significant blood loss or anemia. Primary causes are going to be immature HPA axis. So you want to see, if you see this in an 11 or 12-year-old, basically when they first start having their menses, they can be kind of off cycle, pretty irregular. So that's just immaturity of their hormonal axis. And sometimes they might have anovulatory cycles as well. So you want to treat with iron supplementation for any blood loss anemia, and you can give them high-dose OCPs until their bleeding stops with a taper. Now, the secondary workup would be for anatomical pathology, coagulopathies, or STDs. So if they're bleeding a lot, you want to also look into other history. Do they bruise a lot? Are they bleeding from anywhere else? Because they could have some kind of acquired coagulopathy, which is why they're having very heavy menses. And probably one of the first ones you want to think about, besides like low platelets and just dysmenorrhea, is von Willebrand's disease. That's one of the acquired ones. That's pretty common. STDs can also cause the dysfunctional uterine bleeding as well. Dysmenorrhea is when it was menstrual cramps due to prostaglandin production, and so you would want to treat with NSAIDs and OCPs. NSAIDs, of course, blocking that prostaglandin production, and so that helps with the pain mediated by that disease. Okay, now we get into the guy problems. So guys can have some breast tissue, and so gynecomastia is pretty common around age 13 and 14. There's really nothing to do about this, and it should resolve on its own. Now, testicular torsion or torsion of spermatocord, this is a surgical emergency. You might see a swollen, elevated testis that's in a horizontal line. This is how it looks like, in case you were wondering. So, yeah. You'll also have an absent cremasteric reflex, and you want to diagnose it with a Doppler ultrasound because this can show if there's a testicle that's not getting enough blood flow from torsion. The treatment for this is to detorse it, but you really want surgery on board to do it because you don't want to twist it in the wrong direction. So detorsion fixation is what needs to be done, and you want to do this in less than 6 hours because this is an emergency and you could lose the testis when you have loss of blood flow for that length of time. Another thing that's sort of like torsion, but not nearly as big an issue is going to be torsion of the testicular appendage. So this is another common cause of testicular pain, and it's going to be pain in the upper pole of the testis with a pea-sized swelling or a little blue dot sign. So these you don't need to do any surgery for. It's just a small portion of the testes that has the torsion, and you just treat with NSAIDs. There's no surgery that's needed. Testicular cancer is the most common solid tumor in guys ages 15 to 35. It's associated with history of cortism. Usually it's painless swelling and irregularly shaped mass. You want to work this up with a beta HCG, AFP, testicular ultrasound, and CT chest and abdomen. Epididymitis, this is going to be infection of the epididymis, and it's usually caused by gonorrhea or chlamydia, and sometimes E. coli. So you can present with a lot of urinary symptoms, dysuria, urethral discharge, and fever. The premenstrual reflex is positive, and pain is going to be relieved with elevation of the testis. So those are some things that kind of sets it apart from the testicular torsion. All right, contraception. Our long-acting reversible contraception, that's the LARCs, and those are going to be the Nexplanons and the IUDs. And these are going to be our first line for sexually active teens, because you just do it and you just have it placed, and then you don't have to think about it. So that's why they're recommended, and they're greater than 99% effective. Our OCPs are birth control pills, and this contains an ethinyl estradiol. They're contraindicated in pregnancy, liver disease, any venous thromboembolism, or migraines with aura. So just know that you shouldn't be using these for those conditions. Our emergency contraception is our plan B, and we do this in the cases of unintended potential pregnancies or rape. Levonorgestrel so this is progesterone, and you can give it up to 5 days after unprotected sex, but you should give it ideally just after like 2 days for it to work the best. Condoms are the only contraception with STD prevention as well. So just a counseling thing is that the other stuff that we talked about above doesn't protect you from STDs. All right. Do we want to break for a little bit?
Do you want to break? That's fine.
Yeah.
Yeah.
Because the next sections are really long, and
Yeah.
there's a lot of stuff.
Oh, nice.
Good deal.
Break time.
For the emergency contraception, at least the questions that I've come across are all asking about how do you counsel the patient.
Right. Let's get back to it.
Get it well.
All right, we're almost done. Just 3 more sections. So our next one is genetics. And this was a tough section to do, but I kind of just went over like the basics of genetic inheritance that we should kind of know. And then we went into some of the syndromes that are commonly tested, but I couldn't get into all the metabolic stuff because it gets really, really detailed. So here we go. Just starting off really basic with this Mendelian inheritance. So we've learned this ever since we were pre-med. So our autosomal dominant inheritance, this is where both sexes are inherited and it's present in all generations. You can have father to son transmission at high rates of spontaneous mutations, and you just need one allele to have the disease. You can have germline mosaicism and newly diagnosed phenotype and family with normal parents. And parents may carry germline mutation in their germline cells as well. So you might just see that there's no history and all of a sudden sporadically, boom, you got someone with the disease. All right, autosomal recessive. These are the ones that's of course going to skip generations, and both sexes are going to be affected equally. And so you have increased with risk if you have inbreeding or consanguinity, just because that mutated allele is going to be in that same gene pool and just pass along again and again. So these 2 pedigrees aren't the best example, but here you can kind of see that both males and females are affected, and then you kind of have a skipping generation, not really anyone affected here, and then boom, you got a lot of people here affected, and this generation no one. X-linked recessive, And the big thing to think about is that your moms are going to give this to their sons. This can also skip generations as well, and your daughters of affected fathers are going to be obligate carriers, because the daughters of the affected dads will get their disease X chromosome. And so you see this in hemophilia A, Duchenne, Becker, muscular dystrophies, and red-green color blindness. Now, this isn't the best pedigree to kind of illustrate this, but you can kind of clearly see that you have that mom to son inheritance of the disease. So that's why that one's X-linked recessive as well. All right, imprinting and uniparental disomy. So two examples of these are Prader-Willi syndrome and Angelman syndrome. So this gets a little confusing with the wording, but with Prader-Willi, you have the lack of the paternal gene on chromosome 15 that's inherited from the father. So you're not getting anything from dad, and you get both copies of that from mom. So these kiddos have severe hypotonia at birth, short stature, small hands and feet, hypogonadism, and mild intellectual disability. Your Angelman syndrome is going to be your opposite. So this is your lack of your maternal gene, and you're getting both copies of the chromosome 15 deletion from mom. I'm sorry, you're getting both copies from dad, and then the absence of the gene is inherited from mom, if that makes sense. So this is your happy puppet disorder with the jerky, ataxic movements, microcephaly, hypotonia, seizures, severe intellectual disability, and inappropriate laughter, hence the happy puppet. Your mitochondrial disorders, so your mitochondrial DNA is passed along from mom only. You see a lot of the presentations mosaicism, so they have varying amounts of mutated DNA. So their disease phenotype can be very variable in presentation, depending on how much of the mutated mitochondrial DNA that they get. So these are just a few of them, just to be aware of. MRF is myoclonic epilepsy, red rag fibers, where you have the myoclonic epilepsy, myopathy, dementia, hearing loss. MELOS is mitochondrial encephalopathy, lactic acidosis, and strokes. Lee disease is basal ganglia defects, hypotonia, and optic atrophy. Kearns-Sayre syndrome is ophthalmoplegia, retinitis pigmentosa, myopathy, and heart condition defects. Pearson syndrome is anemia, neutropenia, pancreatic dysfunction, myopathy. Trinucleotide repeat diseases. So Fragile X, this is a CGG repeat that's X-linked. And the presentation in the kids will be intellectual disability, a large head with a long face, large hands and feet, and large testicles. Myotonic dystrophy is another trinucleotide repeat disease, and that repeats the CTG. This is going to be inherited autosomal dominant, and they have myotonia with weakness. So trisomy 21 or Down syndrome. We can pick this up on our prenatal screen with low AFP, low estradiol, or high beta HCG, high inhibin. On ultrasound prenatally, we might see nuchal translucency. So the presentation for this, we should all be pretty familiar with the appearance. We have the brachydactyly with up slanted palpebral fissures, hypotonia. They have speckled irises. There's hypoplasia of the middle phalanx of the fifth finger or clinodactyly. And they have that single palmar crease and the epicanthal folds around their eyes. We should also note the complications of trisomy 21. So there's a lot of defects and complications, including AV canal defects, VSD, ASD, duodenal atresia, Hirschsprung, hypothyroidism, atlantoaxial instability, and ALL. So just common things that are tested. Most common cardiac condition is going to be your AV canal defects. That's the one to think about. But then your VSD, ASD is also associated with that. And then if you have a Down syndrome kid who is interested in participating in the Special Olympics, you want to consider radiographs of their head and neck because of the atlantoaxial instability to clear them for sports.
Yeah, also did my sports meds presentation, so that
Oh,
the
okay.
Special Olympics does require
Yeah.
that, like Will was saying. So they really like to be able to highlight that, the atlantoaxial instability. And then the other thing too as well, if they don't have any other issues, like you're also supposed to tell them that they're not supposed to be in like certain like contact sports or injuries, that they would be more at risk for those too.
So your workup for a Down syndrome kid is going to be, of course, an echocardiogram to look for any heart defects, ophthalmology and hearing eval, thyroid studies because they're at risk of hypothyroidism, karyotype. So usually there's not many indications of a karyotype just because our CMA is really good at getting any kind of trisomies or any like small deletion or insertion genetic syndrome. But we do a karyotype here because we want to look for a Robinsonian translocation. So you won't pick that up on CMA because the translocation could actually be balanced. So there's a 100% risk of recurrence if mom has an unbalanced translocation. That's why it's important to get the karyotype, just so that they can plan for future pregnancies. It really doesn't change a lot of the management, though, for as far as the patient with Down syndrome themselves. The other trisomies we want to think about, trisomy 18. So we have IUGR, intellectual disability. These, in the presentation, they might be what see a high forehead, microcephaly, a small face and mouth. They have these rocker bottom shaped feet with clubbed feet. They have clenched fists and overlapping fingers, and the heart defect that they usually have is a VSD. So 90% of these die within the first year of life, and most of them die from central apneas. Trisomy 13 baby, you want to think about a lot of midline defects. So they have the orofacial cleft, they have abdominal wall defects, they have hollow prosencephaly, micronapnia, GU abnormalities, cutis aplasia, and postaxial polydactyly.
And if it helps, Will, I have a certain mnemonic to be able to memorize both of these. So with trisomy 18, it's like Edwards, like election, E for both. And then since like I think about like an 18-year-old, like kind of like a rocker, like emo kid, so he's got the rocker bottom feet, and you know he's like kind of rocking out with the clenched fist and everything. And you know, like whenever you're emo, you're kind of all like brokenhearted. So with the heart defects, so that's just my silly way of like thinking about it. Like I feel like the more like in-depth sort of like stories I create, the easier I can remember it. And then for trisomy 13 patau, like midline defects, like patau I think like palate. So then you're thinking of the midline defects, like oral facial cleft. And then that kind of just helps you remember like to think like downwards, what else would it affect? Like your abdominal wall, your holoprosencephaly, and then like your genital anomalies, because you're just kind of thinking midline. So maybe that helps.
Yeah, I like it. Next year we're going to have like an emo kid as one of the pictures.
Yeah.
That's how we're going to learn it. I'll put it in for next year. Thanks. All right, so sex chromosomal abnormalities. This is going to be a Klinefelter syndrome where males have that extra X chromosome. So you think of it as like they have an extra X chromosome, so they have more female features. Is kind of how I think about it. So we have a tall patient with gynecomastia, delayed secondary sex characteristic, azoospermia, small testes, and infertility. And so some of these may have some mild impairment to their IQ with some intellectual disability as well. Other sex chromosome abnormality is Turner syndrome or monosomy X. So these patients are phenotypically female with short stature, ovarian failure, gonadal dysgenesis. They lack a lot of secondary sex characteristics like breast development. 50% of these will have left-sided heart defects. So you want to remember these: the bicuspid aortic valve and coarctation of the aorta. The other features you can see is they have a webbed neck, a cystic hygroma. They might have a shield-like chest, posteriorly rotated ears, or lymphedema. And the complications we want to think about is a few autoimmune ones. So Hashimoto thyroiditis, alopecia, vitiligo, GI disorders, gonadoblastoma. And so this is kind of just illustrating all the different widely spaced nipples, short fourth and fifth metacarpal bones, and lymphedema. There's some other less known or less common deletion syndrome, one of them being Williams syndrome, which is a microdeletion of long arm chromosome 7. So these kids are really friendly, they have a lot of personality and very sociable, so they have that cocktail party personality. They have intellectual disability, periorbital fullness with a downturned lip. And for boards, the heart defect that you see in Williams syndrome is going to be a supravalvular aortic stenosis. Wagner syndrome is an 11p13 deletion with those genes being affected. And Wagner stands for Wilms tumor and iridia, so they have the lack of the iris or the lack of the color in their eyes. GU malformations and retardation. Alagille syndrome is autosomal dominant, and this is a deletion in JAG1. They have the triangular facies with a long nose, peripheral and branch pulmonic stenoses, tetralogy of the fellow, and butterfly vertebrae are the common classic presentation of it. DeGeorge syndrome is another deletion syndrome in 22q11, and this is our famous mnemonic from all the way back in med school in step 1. It's our catch-22, and that's going to be cleft palate, absent thymus, congenital heart disease, and it's on chromosome 22. So that spells out catch-22. The other thing to add here is parathyroid hypoplasia. So you don't have your parathyroid glands making the PTH hormone for calcium metabolism. So you have low calcium with this disorder. Our common cardiac abnormalities is going to be tetralogy of the fellow, interrupted aortic arch, VSD, and truncus arteriosus. And that's actually the order in most to least common. Osteogenesis imperfecta. So this is going to be a disorder in collagen that predisposes a newborn or an older child to have a lot of skeletal abnormalities and fracture. So you'll see osseous fragility, bones that shatter like glass, short stature, and specific skeletal findings. So keep in mind that with OI, I think this is a good boards question, that you're not going to see renal hemorrhages or subdural hemorrhage. And when you see these red flags, these are more suspicious of abuse. So you can have someone who easily fractures, but you shouldn't have these findings. Now, there's different types of OI. Some of them are going to be your mild forms, and some are severe and then die very shortly after birth. So your OI type 1 is your most common and it's your mildest one. This is the one you're probably most likely to see in clinic. So they have the blue sclera, they have delayed fontanelle closure, hyperextensibility of their joints, hearing loss, and multiple fractures even before puberty. They also have dentinogenesis imperfecta, which is a weak discoloration of their teeth. Type 2 is most severe, and there's death in the newborn from respiratory failure. Type 3 presents in the newborn with many fractures, and there's also some neurological complications as well. Type 4 is a milder form, but you don't have the blue sclera here. The sclera is white, and you have tibial bowing. And this is from collagen 1 mutations. So getting into the other connective tissue disorders, we have Marfan syndrome. This one's autosomal dominant and affects a fibrillin gene. So you can diagnose with any two of the three: ectopia lentis, or aortic dilation or dissection, or a family history of Marfan. So the presentation, you would see a high arch palate, a dislocated lens, pectus carinatum or excavatum, and mitral valve prolapse. So your complications could be that aortic root dilatation or rupture. So you need annual screening with echocardiograms, just to look out for that. Ehlers-Danlos syndrome is another connective tissue disorder that's also autosomal dominant. This one presents with the hyperextensible skin, hypermobile joints, easy bruising, and dystrophic scarring of the skin. Their skin is very characteristic because you might, when you feel them, they're very doughy, and it feels like there's extra skin. It's actually very fragile and easily torn or bruised. You want to screen for mitral valve prolapse again, and aortic root dilatation, because they can have that as well. Moving on to our skin disorders, we have neurofibromatosis type 1. So this is an autosomal dominant defect in an NF1 gene, and 50% of these are sporadic. Remember how we said there's an autosomal dominant, sometimes we don't have a family history and it just pop out on a family tree. So this is one of them where it's pretty common. So this one, our most common findings are cafe au lait spots. Now, not everyone with cafe au lait spots is going to have this problem. Cafe au lait spots are pretty common and they're usually pretty benign findings. So cafe au lait spots, you need more than 6 spots that are greater than 5 millimeters. And that's just for the prepubescent form. The criteria is different for if they're postpubertal. So at that point, you need greater than 6 spots that are greater than 1.5 centimeters. So cafe au lait spots is one criteria, and another one is a benign cutaneous neurofibromas, and you need more than 2 of them. Other diagnostic features that are suggestive of NF are going to be your axillary or inguinal freckling, optic glioma, or more than 2 Lisch nodules, sphenoid dysplasia, or a first-degree relative of the disease. Okay? So your neurofibromatosis type 2 is going to be, again, autosomal dominant, but this is your NF2 gene. Your diagnostic criteria is going to be your bilateral acoustic neuromas, or a first-degree relative with NF2, with unilateral acoustic neuromas. Other things are CNS tumors, lenticular opacity. And then just a side note, the other disorder, you want to think about a cafe au lait spot, is going to be Kuhn-Albright syndrome, which we'll talk about in a different section. Bye, thanks for coming. So other skin disorder we want to think about is going to be tuberous sclerosis. This one's, again, autosomal dominant. So there you go. Just remember these common skin genetic disorders as all being autosomal dominant. Our classic skin findings, we have 2 of them here. One of them is going to be our ash leaf spots, which is those hypopigmented macules as seen here. And then we have the shagreen patches. So these are these oval nevoid plaques. It looks actually a little bit like a scar to me, but that's what the shagreen patches look like. You can also have facial angiofibromas, corticotubers or subependymal nodules in the brain, renal angiomyolipomas in the kidney, and then rhabdomyomas, which is going to be in the heart that you might see on echo. These kids also have polycystic kidney disease. So infantile spasm is one of the complications of tuberous sclerosis. So if you find it in a kid, then you want to think about working this kid up for TS, because there's a 50% chance they have it if they have infantile spasms.
And with infantile spasms, another like kind of buzzword that they like for you to remember is on the EEG, you might see hypsarrhythmia. So just remember that being associated with it. And the infantile spasms can look like this. And they can have a lot over and over and over again.
Okay, moving on to metabolic disorders. All right, so this is going to get back to our biochemistry and med school stuff, so sorry for bringing up bad thoughts. But so we want to suspect inborn errors of metabolism if we notice acute encephalopathy that's progressing rapidly. So you might just notice feeding problems, lethargy, irritability, vomiting, or unexplained seizures. So some inborn errors like PKU or homocystinuria, they'll present with insidious chronic encephalopathy. Energy defects in metabolism presents with fasting issues. So basically, if they're going too long without a feed, then they're going to be symptomatic because they don't have the same enzymes that's going to break down glycogen or break down fatty acids to keep their sugar levels up and to give them energy. So vascular illness can cause exacerbations of these metabolic conditions. So our amino acid disorders, we have our classic PKU, which is autosomal recessive, and this is a defect in phenylalanine hydroxylase. So they have vomiting, irritability, and eczemoid rash and a musty smell. You diagnose early because if you don't treat these early and they keep getting phenylalanine in their diet, this can actually cause intellectual disability very very severe to the point that they're non-functional in later in life. So you want to diagnose this early, and that's why it's one of those things we look for in a newborn screen. And you need a dietitian for strict restriction of phenylalanine. Our hyperphenylalaninemia is a mild deficiency in the PAH enzyme. And so there's a defect in the recycling of biopterin, and biopterin is one of the coenzymes for the PAH enzyme to work. So these babies can present with severe neurological disease, and it's the same thing. You need to restrict the dietary feed, and also supplement with the biopterin in this case, because there's a lack of it. Tyrosinemia, this is a disorder in metabolizing the amino acid tyrosine, and so you have failure to thrive, hepatomegaly, hepatic adenomas leading to hepatoblastoma and liver failure. And so again, dietary restriction. So if the disorder is in metabolizing that amino acid, you restrict it. So no tyrosine and no phenylalanine. All right, now next amino acid disorder is maple syrup urine disease, and this one is a defect in metabolizing the branched chain amino acid, which is going to be valine, leucine, and isoleucine. So in infancy, they have CNS disease, opisthonos, seizures, and rigidity, and there's of course a maple syrup smell to their urine, as the name suggests. So you diagnose this by doing a urine test to look to see if they have those branched chain amino acids, and again you treat with dietary restrictions. They can't have those amino acids. Homocystinuria, this is a defect in the enzyme cystathione beta synthetase, and they have morphinoid habitus, developmental delay, lens dislocation, and hypercoagulable state. So this is very similar to Marfan syndrome, and the way that we're going to remember this is that with the homocystinuria, it's going to be, think about low. So they have the downward lens dislocation, unlike Marfan's with the upward, and then have low IQ, which is the intellectual disability. So that's how we're going to remember homocystinuria. Okay. Urea cycle defects. So with the urea cycle is basically packages the ammonia and ships it in a nice friendly package that's safe to send through the blood into the kidneys for excretion. So hyperammonemia is the main problem with these defects. Your urea cycle defects are all going to be autosomal recessive, except for OTC deficiency. OTC deficiency is your most common and X-linked. So these kids with the urea cycle defects, they have lethargy, hypothonia, poor feeding. All that's pretty standard, just like all the other metabolic disorders. But they also have respiratory alkalosis. And so in labs, you see high ammonia because they're not packaging ammonia, a low BUN because you need the ammonia to make, you need the recycled ammonia to make the BUN, and you also have the respiratory alkalosis as well. Okay, so moving on to problems of fatty acid metabolism. You have the medium chain fatty acid disorder, which is MCHAD, and that's going to be your most common deficiency where you can't break down the medium chain fatty acids. They have arrhythmias, hypoglycemia, and sudden death, and muscle weakness. And so you diagnose because they have the elevated forms of C8, C8-1, and C8-10 esters. You treat with restricting medium chain fatty acids, and you want to prevent hypoglycemia and fasting, because if they're fasting, then they're going to try to break down fatty acids, and they can't, so that's why they're going to be symptomatic. In fatty acid metabolism, there's also a deficiency in carnitine uptake. So this, in this disorder, the infants will have fasting-induced hypoglycemia, liver failure, and cardiomyopathy. And then you have the LCHAD deficiency, long chain defect in breaking down long chains. And that's going to cause cholestatic liver disease, retinopathy, that you don't see in the other disorders. Okay, the glycogen storage disorder. So there's a lot of them. And unfortunately, there's not a really good way to remember them. But I think the main take-home things is going to be that you're going to have the present form. You have like these two types here. So 1, 3, and 4 are going to present with hypoglycemia and hepatomegaly. And then you have the type 5 and type 2 one, and that one's going to be more with a muscle problem. So that's just kind of one way to think about it. So your type 1 is a G6P deficiency, and basically the liver isn't able to break down the glycogen to supply the blood with glucose. So you need frequent feeds and stuff. That's the same with 3 and 4 as well. Type 3 is a debrancher enzyme, so they're not able to debranch glycogen. And type 4 is a branching enzyme deficiency. So these are the muscle problems. Type 5 is a muscle phosphorylase deficiency. So you have exercise intolerance because the muscle isn't able to supply its own glucose from the glycogen. So that's why you have those exercise symptoms. Type 2 is an acid maltase deficiency. So you build up a lot of glycogen in the muscles, and it leads to the hypertrophic cardiomyopathy and myopathy. All right, we're finally done with genetics. I did skip over some of the lysosomal distorages just because that part got really tedious. So I would say that's the part that we'll have to add on for next time. And if you wanted to brush up on your genetics, or metabolic disorders, that's the part that I left out that was highlighted in that study.
There are some really good YouTube videos on those. I could find them.
Okay.
Yeah.
Yeah, that'll be good. I still have trouble learning all this, but I think that's kind of a good start of the basic stuff for genetics. And I don't think genetics is a huge portion of the ITE. It's probably 4 or 5%. So moving on. So we're on Psych. I forgot we had a Psych session. This should be pretty short. So ADHD. So you have persistent inattentiveness, impulsivity, and hyperactivity. And you basically have concerns in 2 settings. So the parents are complaining that a kid's too hyper and not paying attention. And then the teachers at school are saying that the same thing's happening in school. So you want to have these features in 2 different settings. So that's why in a lot of kids under the age of 5, we have a hard time really diagnosing that because they're not school age and they're not going to school yet. So we want to kind of wait until they're school age to nail down this diagnosis. So these kids have a lack of executive functioning. So they really don't think ahead much. There's not a lot of abstract thought or working memory. They have trouble with response inhibition, so they'll just shout out answers and they'll kind of lose control, and they won't have any control of their impulsive behaviors. So this is going to be boys more than girls. I would say one thing with girls is that they have less of the hyperactivity symptoms, so sometimes they go more undiagnosed. So additives and food sensitivities, there's just been some stuff in the media about how certain dyes can cause it, but the studies have shown that these have little impact or causation with ADHD. So like I said, symptoms are going to be present in all settings, school, home, or daycare. And if you see any discrepancy in symptoms in different settings, like, oh, he's just fighting the teacher a lot, but you don't really notice any problems at home, then that could be some other behavioral thing that's not ADHD. Because you really want to see a consistency in the different settings. So our screen for this is going to be our Vanderbilt and our Connective scales. Treatment for, sorry, we're not on treatment yet. Okay, ADHD diagnosis. Okay, so we expanded now to include age 4 all the way to 18. Our preschool age children 4 to 5 should be managed with behavioral therapies as an initial treatment. And then consider stimulant meds if they didn't respond to those therapies. Now, older children, adolescents, you want to do medication therapy, but you also as an adjunct to the therapy is also behavioral therapy. Our stimulant medication is going to be our methylphenidate, and this comes in many formulations like Adderall or Vyvanse. We should be aware of the side effects, so we can have weight loss due to appetite suppression, headaches, high blood pressure and tachycardia, and exacerbation of tics are pretty common. So if you think about it as a stimulant, so it's going to raise your blood pressure and heart rate too, so that's why we might have those vital sign changes. You want to watch your blood pressure, you want to watch your appetite and watch where their weight is on your growth curves, and then also their sleep hygiene. There's also comorbid substance abuse in our teens, so you want to counsel them about drugs and alcohol and medication misuse as well. Okay, so going into the disruptive behaviors, ODD is oppositional defiant disorder, and you have recurrent negativism, defiance, disobedience, and hostility towards patients, teachers, and authority for more than 6 months. Our conduct disorder, this is where we're getting into a really bad kids who are breaking the law. So this is going to be oppositional and defiant behaviors, plus those, and this is what sets it apart from the ODDs. You have those antisocial activities, breaking the law, meaning lying, stealing, setting fire to things, and animal cruelty. And these kids usually have no remorse or guilt whatsoever. All right, autism spectrum disorder. Our DSM-5 criteria for this includes impaired social interaction, impaired communication, restrictive or repetitious behaviors or interests or activities. So they can be abnormal function in social interaction, language, or imaginative play before the age of 3. And then we really, to meet the criteria for ASD, these clinical features cannot be accounted for by Rett syndrome or childhood disintegrated disorder. OCD is obsessive compulsive disorder. So this is a syndrome of repetitious rituals and behaviors, and these are the compulsions. And they're driven by these recurrent thoughts, which are obsession. And they can cause a lot of distress and anxiety in a person. That's when you have OCD. So obsessions are persistent recurrent thoughts. They're intrusive, and they can be like senses, ideas, and impulses. Our compulsions are going to be those actual behaviors that we do to satisfy the obsession. So like repetitive hand washing, obsessively toothbrushing, checking alarms, arranging objects in certain ways. Because like we're told by our compulsions, by our obsessions that we have to do that. One thing to be aware of is something called PANDAS, which is Pediatric Autoimmune Neuropsychiatric Disorder. I love that acronym. They did a good job with that. And that's associated with streptococci. Okay, and so when you have group A strep antibodies from recurrent strep infections, sometimes this can cause OCD syndrome. So just be aware of that. All right, depression. We see this very commonly in our adolescents. So our criteria is 2 weeks of depressed mood and irritability with 5 Ziggy caps. The Ziggy caps being sleep, interest, guilt, energy, concentration, appetite changes, psychomotor agitation or retardation, or suicidal ideation. So we need 5 of those to meet criteria. So we don't want to confuse these with other disorders. So there's symptoms that's happening within 3 months of a stressor. That's more of an adjustment disorder instead of depression. If they're chronically depressed for over a year, it could be more a dysthymic disorder. And if there's depression, but then they have alternating episodes of mania, of increased energy, pressured speech, then that's more like cyclothymic disorder. Okay, so our depression treatment is multidisciplinary. We need individual family therapy, cognitive behavioral therapy, and then of course medications. Medications first line being SSRIs. So once started, they're not going to notice any changes yet. You got to keep going, continue for a minimum of 6 months. Only fluoxetine and this escitalopram are FDA approved for it. TCAs are another medication you could choose, but they're not going to be first line. There's a lot of significant morbidity and mortality because, well, guess what? These depressed kids who are on those medications also have increased risk of suicidal attempts and drug overdoses. And what are they going to overdose on is probably their medications, which is the TCAs, and those are high-risk medications to OD on. So you want to hospitalize these patients if they have suicidal ideation, homicidal ideation, any psychosis, mania, or substance abuse. All right. So we powered through Psych. We have emergency medicine. And so this section I don't really like the way it's done in med study, but I kind of followed the overall outline. So a lot of stuff that they had in a lot of stuff that you should know for emergency medicine is going to be covered in other sections, like respiratory distress, or say any trauma, things like that. So a lot of what this is just going to be specific to EM, and so it's going to be a lot of ingestions and a lot of bites and stuff like that. And stuff like fractures will be covered likely in a section on ortho. So moving on, emergency medicine, poisonings and ingestions. We're going to be on this for a long time because there are a lot of drugs that kids OD on. So overview, most are unintentional and the peak age is 18 months to 3 years of age. Males more than females in those little taller age ingestions. Then you get into the teenagers where ingestions happen again. In this case, they're intentional and they're going to be more females than males. In general, when you have an ingestion, things you want to look out for is pupils. They can give you a lot of clues as what it could be. So your meiosis is going to be the pinpoint pupils. So you want to think of the mnemonic COPS. So cholinergics, clonidine, opiates, organophosphates, PCP, phenothiazine, pilocarpine, and sedatives. Okay. Dilated is going to be with mydriasis, and so the mnemonic is AAS. I don't think that's a really good mnemonic, but whatever. Anticholinergics like atropine, antihistamines, and sympathomimetics like amphetamine, cocaine. The skin can also give you some clues too. So cherry red skin, you will see with the carbon monoxide poisoning. Cyanosis, you can see with methemoglobinemia or hypoxemia. So the general management for these poisoning ingestions. If they're severe, you may have to think about your A, B's, C's, and D's first. So your airway, breathing, circulation, that comes first before anything else. Your D is one that we don't talk about much, but it's important for any ingestions because disability and decontamination being the key feature here. If they had poisoning with some kind of organophosphates or something that's stuck on their clothes, they're going to continue having exposure to that. So you want to decontaminate them so that you get rid of the exposure. Same thing with the ingestion of caustic substances. Sometimes they can get it all over their skin too, so decontamination is one of those first things you want to think about next to airway, breathing, circulation. Always check your bedside glucose, especially in the cases of altered mental status, because some of these ingestions can drop your sugars. You want to do EKG for cardiotoxic agents. That's going to be your TCAs or any blood pressure medications. Now your urine drug screen is not going to be too helpful here because a lot of these are just ingested random substances, fertilizers, random chemicals, cleaning agents, or drugs that are like prescription drugs, not like abuse drugs. So your UDS isn't too helpful. There's some blood levels that you can get, and these are for your Tylenol level, or your salicylate levels for aspirin, or iron levels for iron pill ingestions. Okay? And I think I already talked about this. Decontamination is important. Remove clothing and wash the skin, for especially if they had exposure to like fertilizers and stuff. Ocular, if they had some eye involvement, you want to remove fragments and irrigate the eye. And GI stuff. So GI decontamination is, we really don't like to do it, and it's usually not that helpful because unless they came in like within 4 hours of ingesting it, it's usually already absorbed and too late for decontamination. So I would say if you see that on a test, I would think about other things besides GI decontamination because there are very few instances where you would do that. Okay, so a little bit more about GI decontamination. Activated charcoal is probably the main thing that you would do. And I'm sorry, I misspoke when I said 4 hours. I meant ingestion within 1 hour. So that's very soon from the time the kid took it to when they had to come to an hour. So that's why a lot of these things aren't that useful. So your activated charcoal is probably one of the ones that you would actually use for decontamination. So the ingestion would have to be in 1 hour. You don't want to use it in certain cases with like the chemicals. And so there's this mnemonic, so stuff that's caustic, hydrocarbons, metal, iron, alcohols, lithium. Those things you want to avoid using the charcoal. Gastric lavage, we rarely use this as well. And you only do it if it's 30 to 60 minutes after a life-threatening ingestion. When you do this, you need to be careful because of airway protection. Whole bowel irrigation, this is just to flush the GI tract so that it gets out of the system faster, but this really isn't too useful, especially if it's more like a long-acting release substance. Oh, sorry, it's more useful, sorry. If it's long-acting release, then it's more useful because you want to get it cleared from your system faster. That's what I meant to say. There are cathartics which do the opposite, so it decreases the GI transit time, and those aren't too useful. And the Ipecac solution, this induces vomiting, and you really don't want to do that because when you have vomiting, you have risk of aspiration, and you really don't want all that caustic or whatever's ingested to go in the lungs. So you want to avoid that one. Our anticholinergic poisoning, so our mnemonic that we know is going to be on dry as a bone, red as a beet, hot as a hair, blind as a bat, mad as a hatter. And so we think about atropine or antihistamines that are causing the anticholinergic symptoms. So we have dry, flushed skin, hyperthermia, we're all red. There's really large dilated pupils. There's urinary retention, ileus, agitation, and delirium. Then we have our opposite, which are cholinergic poisoning. And they have muscarinic receptor and nicotinic receptor effects. And so these can be caused by insecticides. So we think about dumbbells from our muscarinic effects: defecation, urination, meiosis, bronchuria, bronchospasm, bradycardia, emesis, lacrimation, salivation. And then there's our nicotinic effects, which is muscle weakness, paralysis, and CNS effects. Our opioid poisoning, we want to think about everything decrease if a kid took some opiates. So we have a decrease, so CNS depression, meiosis, those small pupils, respiratory depression or apneas, low heart rate, and low blood pressure. So clonidine is going to cause similar symptoms with opiate poisoning as well. For these kids, you want to intubate them if you need to. Remember those ABCs. You can consider activated charcoal, and you can do naloxone, which is going to be your opioid antagonist, but you got to be careful because they might have withdrawal symptoms if you use that. Sympathomimetic poisoning, think about everything being elevated. So in these cases, you got agitation, tremors, hallucinations, seizures, high heart rate, high blood pressure. They have dilated pupils, and they're sweating a lot. So examples of these are going to be decongestions, because a lot of these have pseudoephedrine, so that's why they stimulate the heart and are vasoactive, and then cocaine and amphetamines also do that as well. Tylenol ingestion. So this is an ingestion we probably want to all know about because we're going to see this the most in our hospital. So acetaminophen ingestion. An overdose depletes the stores of glutathione. And remember, glutathione is protective from oxidative damage. And so when those are depleted, we make the toxic metabolite NAPT, which causes liver damage. So the minimum toxic dose for children less than 12 is about 150 mg per kg. So that's like 10 times the normal dose. I guess how we can remember it. So for adolescents, it's going to be a little bit more. It's going to be 7.5 grams to 10 grams. So early on, you're not going to really see much. For the first day, they'll have normal LFTs, no symptoms. From after 24 hours to 72 hours, they'll have some mild symptoms and mild lab changes. So they'll have some right upper quadrant pain, some increase in their LFTs or INR. And then after 72 hours, we get our peak symptoms. And this is when we have fulminant hepatic failure or coagulopathy if we have really severe ingestions. So our treatment for this, we can give activated charcoal. We can check the Tylenol level 4 hours after ingestion. And at the 4-hour mark, this is when we can use our normogram to decide whether we give an acetylcysteine treatment. So based off how much was ingested and what time. If you're above this line, this is where you would treat with NAC. So sometimes you might just treat with NAC empirically if it's a delayed presentation or there's substantial like overdose where they took just lots and lots of Tylenol. Of course, you want to call that poison control hotline and get that toxicology consult because they'll be able to help you out with that as well. Okay, other drug poisonings, salicylates, so like aspirin. So this can cause nausea, vomiting. The big one that kind of stands out are going to be tachypnea, which is going to cause that respiratory alkalosis. And so CNS effects, fever, that's kind of non-specific. Tinnitus, that's something that's more specific to your aspirin ingestion. You can alkalize with the urine with sodium bicarb to help with the elimination for these. And another thing about salicylates, that's one of those that you're going to have an elevated anion gap metabolic acidosis. So if they take blood pressure medications, they can have low blood pressure because that's what the medicine does. So bradycardia, hypertension, hypoglycemia. We want to consider activated charcoal, food resuscitation, and giving IV dextrose for hypoglycemia. You can give atropine for bradycardia, but only if it's calcium channel blocker ingestion. For clonidine, this one you got to watch out for because just one pill can cause toxicity. And it's the same thing as the opioid toxicity that we talked about with all those things being depressed. Our iron ingestions, these can be really serious because the adult iron pills has a lot of iron, and the amount that's ingested really matters in these cases. So if it's less than 20 mg per kg, they're mild or asymptomatic. If they're 40 to 60, they can have moderate toxicities, and more than 60 mg per kg is going to be severe toxicity. Our initial symptoms are going to be GI upset, so non-specific nausea, vomiting, diarrhea. Sometimes they have blood in their vomit, blood in their stool. But later on, they can have the shock, severe anion gap metabolic acidosis, liver failure, and coagulopathy. On x-rays, sometimes you can actually see these pill fragments because the iron shows up radiopaque. You want to get the serum iron about 4 to 6 hours after ingestion. If they took in more than 40 mg per kg, is that magic number. And then you have different cuts off for what's a toxic level and what's a non-toxic level. So above 350, then you're more concerned. There's an IV chelating agent for iron called deferoxamine, and you want to give it for moderate to severe symptoms or the levels are greater than 500. Okay, TCA ingestions, so you have CNS effects, and then you can get, these are really deadly because of the intractable hypotension and the cardiac toxicity with tachycardia, widening QRS, and prolonged QTc. So the cure for this is sodium bicarb to prevent the QRS widening, IV fluids, and treating the seizures with benzos. And you want to follow the EKGs after you give the sodium bicarb to see that the QRS is narrowing appropriately. Oral hypoglycemic agents. Just like clonidine, these are, again, one of those one pill can kill. And the ones that are scary are sulfonylureas. These are also known as insulin secretagogues because they stimulate insulin production. And that can cause the glucose to drop very low into deadly levels. So you want to give dextrose and give glucose replacement as needed. Serotonin syndrome is seen with polypharmacy of SSRIs, Mao-I's, fentanyl, ecstasy, meth, linazolid, or tramadol. And so it presents with fever, confusion, diaphoresis, and myoclonus. So those are pretty non-specific symptoms. And there's a lot of overlap with these symptoms and the neuroleptic malignant syndrome. The treatment for serotonin syndrome is supportive. That's not anything that you get for that. Now, with your neuroleptic malignant syndrome, these are going to be a drug reaction to your antipsychotics or metoclopramide.
With serotonin syndrome, you can actually give ciprofloxacin. Actually, I had a kid in the PICU with it. Yeah, I can't remember the mechanism right now, but whenever we called poison control, it's the treatment for it. But
Oh, it is?
med study didn't have it within there.
Yeah.
an interesting thing.
So yeah, neuroleptic malignant syndrome will present a lot of the same things. So you have the hyperthermia, you also have rigidity, confusion, some autonomic changes. But what's a little bit more specific for neuroleptic malignant syndrome is going to be that they have that lead pipe rigidity. So rigidity is the most pronounced thing that kind of sets it apart from the serotonin syndrome. You can also have acute dystonic reactions to antipsychotics as well, and for those you give diphenhydramine or benstramine. And I'm trying to remember why I have a blue star now, because the blue star means it's a mnemonic. And it's bugging me now why I can't think of it. Okay, it's not coming to me. Our poisonings, so these are ones that cause disorders of hemoglobin. So our hemoglobinemia is where we have iron converted to the ferric form instead of the ferrous form. So the ferric form can't bind an oxygen, so that's no bueno because that's what iron's there for in the hemoglobin. So what causes that are nitrites, nitrates, aniline dyes, local anesthetics. So this is a really cool fact. Apparently, adolescents who pop like Viagra or something will get like too much nitrates, and then they can get poisoning that way. I thought this was really random. Never heard about it, but it's a meta study, so I just thought I'd put it here. So they have like this chocolate-colored blood, and you have to be careful because the O2 stats and the PaO2. Neither of those are actually reliable in this case because it's not really, because the defect's more in like the iron. So you can't really rely on this. You need to, if you really want to test it to see what the oxygenation is, how the delivery of oxygenation is, you need to do something called co-oximetry. So treatment for this is with oxygen and methylene blue. And so my mnemonic for this, it's a dirty mnemonic. So oh yeah, so just to remember like the adolescence and like popping like sex meds to increase their sex drive. So my mnemonic is blue balls, blue blood, methylene blue. So there you go. And then our other hemoglobin disorder is going to be carbon monoxide poisoning. And so there's colorless or odorless gas. And so you can get poisoning if there's stoves that you don't have proper ventilation, if there's car exhaust that you're not ventilating, portable generators or smoke inhalation. Your symptoms are just kind of like non-specific headaches, malaise, nausea, flu-like symptoms. But then you get that cherry red skin, which is pretty specific, but you don't see that all too often. Again, you can't rely on your PaO2 and O2 stats. You got to manage the co-oximetry or getting a carboxyhemoglobin level that's greater than 15 to 20%. The treatment for this is going to be high flow oxygen, and in really severe cases, you need to get hyperbaric medicine and get hyperbaric oxygen treatments. Okay, here are some environmental exposures. So caustic substance ingestions, you have the base and the acids. So your alkaline or your basic chemicals like bleach, ammonia, drain cleaners, detergents. Your acids are going to be like toilet bowl cleaners, rust remover, battery liquids, metal cleaners. So they present with mouth and throat pain, drooling, refusal to eat or drink, nausea, vomiting, hematemesis. You want to decontaminate them again. IV fluids and nothing to eat. And do not induce vomiting again, because you don't want them to aspirate that stuff. You got to do an EGD for symptomatic kiddos, because you want to look for any perforation or strictures, which are pretty common complications with these caustic substance ingestions. Another thing is the hydrocarbon ingestions. So you see this in like teenagers who are huffing weird chemicals or things like that. Camphors, aromatics, metals, or pesticides. They can get cardiac arrest from a ventricular arrhythmia. You want to decontaminate again, monitor them and watch them for aspiration, but this treatment for this is supportive. Okay, so our alcohol ingestions, our favorite ingestions here, these can have high osmolar gaps and anion gaps. Our methanol injections, so these are obviously in our beverages that we so enjoy, but they're also found in mouthwash and perfume. We are well aware of the symptoms of toxicity, including CNS depression, respiratory depression, nausea, vomiting, hypoglycemia, hypothermia. Again, think everything down, just like the opiates. Treatment for this is supportive. Nothing to do for it. They'll be fine. Our methanol ingestion, we got to be a little bit more worried about. So we can find the methanol in windshield washer fluid, de-icer, fuel additives. We really worry about the eye toxicity. So we get blurry vision, photophobia. There's optic nerve damage that can lead to blindness. So we got to treat this. So you want to give sodium bicarb for metabolic acidosis, and we give IV for meprazole, which kind of blocks the enzyme that metabolizes the methanol. And we also give folate as well. There are some cases where you can get like actual ethanol because of the competitive inhibition, so that the enzyme chooses to metabolize the ethanol instead of methanol, but it's not really recommended to do that. But that is like one of those other treatments. Ethylene glycol ingestion, so these things are found in antifreeze and coolants, and these are also something you got to watch out for because the ethylene glycol can cause renal failure in severe cases. Again, you got a high anion GAD metabolic acidosis, so you want to treat it with sodium bicarb, IV from meprazole, thiamine pyridoxine. Okay, so foreign body. We don't go into foreign body aspiration. I think we have that in a poem slide, but this is just for swallowing foreign bodies. It's our esophageal foreign body. Our peak in age of ingestions are going to be 6 months, all the way to 3 years. It's usually in coins and found in the upper or lower esophageal sphincter or aortic arch. We're going to diagnose with a two-view chest X-ray and abdominal X-ray. If they are symptomatic, we're going to remove them endoscopically. But if they're asymptomatic, we can watch them and just watch if they pass it through past the stomach. Now, if it's a blood battery, you got to remove that because that can be caustic and cause a lot of erosions and problems. You want to look for a double ring sign or a poker chip sign on AP radiograph. And I'm sorry, I just didn't put a picture here. I really should have, but I think that's pretty self-explanatory. But you look at that double ring, which you have when you go on batteries, and it also looks like a poker chip. Okay, I think that's all for the swallowing ingestions. I know that was a tough part to get through. Now we're getting into the different bites. So we got animal bites and human bites. So our cat bites, these are going to be from Pasteurella or Staph aureus as an organism. Our dog bites are going to be the same bugs, but then there's another one that can have is Capnocyta vega. You can have puncture wounds, especially with the cat bites, and they may need radiographs or local exploration of the wound. You want to treat this with Augmentin, and primary closure is actually not recommended for a lot of these bites. Our human bites, usually it's not like a human actually biting someone. What they are fight bites. So if the kid gets into a fight, they punch another kid in the jaw, and then that's basically what happens, that they got like this bite mark on their hand or knuckle. So that's what they mean by fight bite. So for these, you want to irrigate, and you can x-ray the knuckle for injury and look for tendon damage. That's really the main treatment that you do. For our snake bites, these are the poison ones we want to think about are pit vipers like rattlesnakes, water moccasins, and copperheads. There can be localized swelling, ecchymosis, and necrosis around the wound, but it can also cause systemic coagulopathy and neurotoxicity. So, unlike popular belief, we don't want to apply pressure, we don't want to try to cut it out, we don't want to suck on it, and we don't want to apply a tourniquet. What you want to do is just immobilize the body part and remove anything that's constricting so that it gets good blood flow. You want to check DIC panels and coags, and then CK and UA just in case there's rhabdo. So the antidote for this is Crofab, which is crotalidase antivenom, and you want to give it within 6 hours. And you titrate the dose depending on how much venom was injected into the body. Our spider bites are two ones we want to think about as our brown recluse spider. So these ones have that fiddle pattern or violin pattern on their back. I didn't pick the best example, but that's kind of what they're referring to. It's a painless bite which can progress to a hemorrhagic blister, and it could even lead to like necrotic ulceration, which is going to be your cutaneous loxoscelism. Your black widow spiders have that red and orange hourglass mark on the ventral part of their bellies. And so this is a painful bite, unlike the painless bite of the brown recluse. This one has neurotoxic venom, and you can develop diaphoresis, muscle cramps, chest pain, vomiting, abdominal pain. Okay, moving on to our burns. Burns are a leading cause of unintentional pediatric death. So these are our different stages of our burn. So our first degree, it just affects the epidermis. It's very superficial. It's just some redness, and it has maybe some blanching, and it's really dry. So you can think of these as just if we're just out in the sun for a few hours, a little too long. Now, our second degree burns are a little more serious. They have partial thickness involvement down to the dermis, blistering. They can be pretty moist and painful, and you might see some bullying as well. Our third degree are going to be full thickness, and it can be dry, leathery, kind of waxy, and then the skin is actually not tender like you would see in first and second degree, because they've lost a lot of that sensation because it's affecting all the layers now on the skin. There are different ways to determine how much burn involvement of the skin, and one of them is rules of 9, which you use in older kids or adults, and you can use this diagram. Basically, each leg is like 9. Both arms would be 9, and then the front side of the torso is a 9, the back is a 9, and then the front and back of the head make up a 9%. So you can kind of do that to see how much of the skin was involved. There's something called a lung Browder chart if they have for smaller kids. The other thing you can do is just estimate with the child's hand, and the surface area of the child's hand would be about 1%, so you can use that. And this is the lung Browder chart to kind of tell for your infants and toddlers, kind of see how much of your skin was involved in their burn. The reason we do that is to kind of see how much of the fluids we need to give back. So that's where I'm getting to the Parkland formula. So we want to give back 4 cc's per kg for each % of body surface area burn in the first 24 hours, and then 50% of next, and 50% in the first 8 hours. So our minor burns, you just need to keep the area clean. You can use antibiotic ointments and dressing. You can leave the blisters alone if they're less than 2 centimeters. But if they're bigger than that, you might want to consider getting surgery to excise those blisters. The major burn care, remember the IV fluids we're giving back is just because burns lead to a lot of insensible losses of water from the skin, so you don't want them to get dehydrated. ABCs are important if you're concerned about burns in the case of like a fire, especially if you see like soot around their nares, then you want to consider intubation early on because there's an inhalation injury. Electrical burns are going to happen when you have exposure to a high voltage of 500 to 1,000 volts. And so the AC currents are more dangerous than DC, because the AC ones, if they get electrocuted, it causes muscle tendony, and so they grab onto things longer. So that's going to be causing a more severe burn. Your household AC current is going to be 110 to 240 volts, and it's usually minor, and you just need wound care. Biting the electrical cord is serious because it can cause a lot of bleeding. And high voltage can cause asystole, VFib, a respiratory failure, thermal bones, and deep tissue injury and compartment syndrome. All right. Drowning. So it's summertime, so we want to think about this because we see it in the hospitals quite a bit. This is our second most common cause of accidental pediatric death with PHs, less than 5. And then we see it again at ages between 15 to 25. There's some things that lead to good outcomes, and one of them is actually cold immersion, because when the body is hypothermic, it prevents like a lot of metabolism and worsening of the hypoxemic, ischemic injury in the brain. So our poor outcomes are going to be submersion greater than 10 minutes. If you're waiting more than 10 minutes for CPR from the time the kid drowned, if your resuscitation is taking more than 25 minutes without a pulse, if they're under 3 years old, if their glaucoma scale is less than 5, if their water is on the warm side, or if their body pH is less than 7.1. So again, ABCs. If they don't have a pulse, you do chest compressions. Sometimes in these diving accidents, they can have neck fractures, so you want to also protect the C-spine before doing chest compressions. And then you want to warm them up if they're hypothermic. But I actually kind of question that, because the hypothermia is protective. So I want to say maybe early on you don't do that. But I think this part's questionable, but I know I found it in a med study. But I wasn't too sure about that. I'll have to look into it a little bit more. Head injuries and concussions. So our symptoms of this after a head injury could be loss of consciousness, amnesia, vomiting, lethargy, headaches, irritability, seizures, and behavioral changes. There are a few red flag signs where you might be more concerned about a head injury causing a brain bleed. And so if you have a basilar skull fracture, raccoon eyes, or the battle sign, which is going to be the bruising like around behind the ears, hemotympanum, CSF leakage from the nose or the ears, cranial nerve palsies or hearing loss, that's not good signs. You also want to look out for signs of renal hemorrhage or subdural hematomas, because again, you see those more abusive head traumas. The epidural hematoma, we want to look out for, because we see this classically where these patients had they got knocked in the head, and then they have this period where they're lucid and clear. And then the Cushing's triad is kind of a late finding, but it's very bad when you have bradycardia, hypertension, and hyperthermia, which is going to be irregular respirations. So your Cushing's triad suggesting that you have brain injury suggesting impending herniation, so that's really not good. With head injury and concussions, our management is, and our question we usually get about management is like, do you CT or do you not CT when this kid comes in the ER? So CT head without contrast is our best imaging modality, and what we use to decide whether we do the CT head is going to be our PCARN scoring. So with this decision tree, basically if you have a GCS less than 15, altered mental status for a palpable skull fracture, that's automatically go to CT. And then after that, if you pass that first part with those first 3 screening questions, you would look into some other concerning features. So is there a hematoma on the scalp? Did they lose consciousness for more than 5 seconds? Are they not acting right? Or have any headaches? And if they have yes to any, you can kind of consider observation versus CT. If there's not any of these, then you don't have to worry about it. You kind of ruled out any indications for CT. Now I have 2 decision trees here, because one is for less than 2 years old, and this is for greater than 2 years old. But the overall questions in this first part is the same, and then here it differs a little bit based off the symptoms. All right, so going on more about head injury. So concussion is going to be a mild traumatic brain injury. So catastrophic head injuries due to football are 3 times more likely in high school than in college, actually. A lot of these symptoms are going to be headache, amnesia, confusion, dizziness, nausea and vomiting, altered balance. They can have some transient vision loss, persistent headaches, difficulty sleeping and concentrating. I mean, a lot of these actually don't even have any loss of consciousness. So when you're managing a concussion, there's no return to play the same day. They gotta sit it out. And because of the risk of second impact syndrome. So if you have repeat injury after a concussion, this can actually be fatal. And if you have repeat concussions, you can have really chronic neuropsychiatric deficits later on. So we recommend patients be asymptomatic before resuming activities with 7 to 10 days with gradual progression of light activities. So this is the recommended treatment for concussions. So basically, that first day after they had an injury, I would say do almost nothing. It's like all bed rest. And then if they're doing fine, the next day they can do some very light activities, just basically activities of daily living. They can maybe go to school, but not engage in anything physical. They can take a walk, but no strenuous exercise. And then if they do well the next 2 days, then they can move on to the next step and slowly do some light exercises, light aerobics, but nothing heavy. And so they keep on going until they're basically ready for their heavy exercise and the full return to play. Now, if they have any more symptoms, they don't tolerate any one of those steps, then they need to maybe take a step back, maybe do less exercise and less activities before they can proceed on. Okay, our fractures, we're going to cover this more in the ortho section, but be familiar with the Salter-Harris classification for fractures. So they have like the mnemonic where you just spell out Salter, and so your Salter, your type 1 is just going to be through the growth plate. Your type 2 is that A is going to be above the growth plate. Your type 3 is the L, which stands for lower, which is below, which is through the growth plate and below. And then the T is going to be through all elements. It's your type 4 that extends through your epiphyses and growth plate and diaphyses. And then your type 5, which is going to be your crush injury of the growth plate. Okay. Oh, I have it here. Okay, good. This we need pictures for this part. So our fractures that we commonly see, green stick fracture is going to be incomplete fracture where the cortex is only broken on one side. And the one I have showing green stick is here. So you see this side's okay, but then you can see where it's broken on that radial side. And then the other one, torus or buckle fracture. This is going to be a compression fracture causing buckling in the metaphysis. You commonly see this in the distal radial metaphysis. I don't have a picture of that one. The spiral fracture is a curvilinear course from twisting mechanism. You can actually see this in minor falls, and they can be from accidental toddler fracture. But if you're ever concerned with a history, it's like inappropriate, or they're talking about a child that's non-ambulatory who has this toddler fracture, that's a no-no because that doesn't fit. So that spiral fracture is going to look like that. You can see that curvilinear path on X-ray. Clavicle fracture is the most common fracture in children and results from falling on the outstretched arm or direct trauma to the clavicle or upper chest. You want to treat this with immobilization with an arm sling. Lastly, we've got the supracondylar fracture, and it's also caused by a boosh or fall on an outstretched hand or elbow. And this one has the posterior fat pad sign on X-ray. Sometimes you can have a displaced fracture, and these displaced fractures have risk of neurovascular compromise, compartment syndrome, nerve damage. And so this is going to be that supracondylar fracture with the posterior fat pad sign. That's what I'm trying to show right here. Okay, so there's other joint injuries to be aware of. One common one is going to be the nursemaid's elbow, and so this one is called formal term for it is subluxation of the radial head. And basically, the classic history is that you have a toddler and mom's trying to pull them to come this way, and what it costs is the radial head to kind of pop out of where it was in. And so we just need to put that radial head back where it belongs. So the treatment for that is to pronate and extend the forearm to reduce. Likewise, you can also supinate and flex. And while you're doing the maneuver, you want to put pressure over the radial head to put it back in place. Sorry, radial head being here. Sprains are rare in prepubescent children. You're going to see them more in the adolescents. And you want to think about your auto-wide ankle rules. And your auto-wide ankle rules is what's going to decide whether you x-ray that foot or not. So you get an x-ray of the malleolus if either one, you can't bear weight for 4 steps, or 2, it's tenderness on the distal posterior aspect 6 centimeters from the malleolus. Your treatment for sprains are going to be your rise, your rest, ice, compression, elevation. And if there's significant sprain, they may need a splint. Okay, we're getting into some eye stuff here. Corneal abrasion. This is going to present with eye pain, tearing, photophobia, and blurry vision. The way you diagnose this is with fluorescent dye. And you get a Woods lamp, and the dye is supposed to help look for any foreign body of the eye. You can treat with topical antibiotic ointment for any abrasions or ulcers, but you don't want to use any anesthetic eye drops. Hypedemas, this is what's shown in the picture, and this is blood in the anterior chamber, and this is usually caused by physical injury. You treat this with some topical steroids and cycloplegic drops, but you want to avoid any pressure increases from pain or vomiting, because this can cause intraocular pressure and a rupture of the globe. Then you have your orbital blowout fracture. This is caused by trauma to the eye that breaks the walls around the eye in the orbit, and this can cause extraocular muscle injury. So sometimes they have diplopia if they have like those palsies in like cranial nerve 3 or cranial nerve 6, and they can also have cheek numbness as well from cranial nerve palsy. All right, I think we're on our last section, and this one's a short one. All right, everyone doing okay? All right, let's take it home. Child abuse. Higher rate of child abuse is going to be our infants from birth to 1 year of age. Boys are more affected than girls by physical abuse, but girls are affected more than boys by sexual abuse. As a physician, we are of course mandated to report all of these cases to CPS, Child Protective Services, and then if we find that there's a unsafe home situation where a child cannot go home safely, then they need hospitalization. Hence those social admits that we so love and enjoy. Physical abuse is going to be any act that results in harm, intended or unintended. And so the concerning features of these is that if you have like a history that doesn't fit the mechanism of injury, or if you have like a history that doesn't fit the child's age and development. So if you see something that's concerning for like toddler fracture, and they say, oh, in the 6-month-old, and they say, oh, he was walking and then he fell off the couch and then had this fracture. Like that doesn't really fit, because we know that 6-month-old shouldn't be able to walk around and shouldn't develop that kind of fracture. You might have an unexplained delay in medical care. You could have recurrent injuries, or history with an abuse or an unexplained death in a sibling. Those are some other red flags. So, like I said, you want to think about the milestones. That 1-year-old learning to walk may have some bruises, because that 1-year-old still learning will have some falls from time to time, but at 6-month-old, probably not getting up to learn to walk just yet. Okay, so physical abuse features, our soft tissue injury can be from bruises and welts, like we see here. And the general progression of bruises they'll start out kind of red and swollen, and then they can change different colors like red, blue, and purple. But there's really no way to date the bruises. Like you really can't look at it and tell how old those bruises are. And you also don't want to be tricked by some other things that kind of look like abuse, but aren't, like Mongolian spots, which we very commonly seen, especially in African Americans along their buttocks and backs. And then there's also things like Biophotodermatitis, or traditional treatments like coining or cupping. So this is just cupping treatment, and that's what causes those spots, which look a lot like bruises or some kind of trauma, like they got hit by a baseball or something. But no, that's just cupping. Burns. So if you might sometimes see this with an immersion pattern. So in like a baby or toddler, if they see that pattern, that's not an accidental burn, because you can clearly see the pattern is consistent with like someone who was dunking the infant into like a hot water. So that's what classically looks very much like an immersion injury, not like a splash injury. Now the splash injury, that one I might buy a little bit more. That's probably more like an accident where they actually spilled a pot of hot water or soup and then it got on the babies with a splash marks. So you want to look out for that immersion pattern where it's sharply demarcated and usually involving like the legs or butt. A lot of cigarette burns, that's also suspicious of abuse. Can't really say that's an accident. Okay, so serious head injuries in abuse. These are commonly seen in the kids less than 1 year of age, and it's a leading cause of child abuse death. So we think about this with subdural or subarachnoid hemorrhage, and we see bilateral retinal hemorrhages. The symptoms are vomiting, fussiness, lethargy, coma, and apnea. We can even see some bony fractures with other significant child abuse. These being the corner fracture or the bucket handle fracture, and these are with yanking injuries causing convulsion fractures. Femur, posterior rib fractures, or skull fractures, these are highly suspicious for abuse because they're not places that you usually fracture. Femur being such a big bone and like one of the stronger bones in the body. Posterior rib is also an unusual place, and then skull fractures. So, yeah.
One that I've picked up too with a couple of questions is they'll always ask like about bruises like around the ears. They always kind of point out that that's like a really odd like looking bruise. So if you get like a bruise around there, just kind of take it as like a potential buzzword for abuse.
And then other injuries, if you might want to think about liver laceration or traumatic pancreatitis, and you would see some other signs. So if you have concerns that they have like petechiae or bruises over their abdomen, or they have fractures everywhere that was picked up on skeletal survey, or just any kind of major trauma, you want to think about it as abdominal injuries because they can be pretty significant too. So I saw one of these that presented with just some bruising over the abdomen, and so we got liver enzymes and lipase, and so they can have liver laceration, traumatic pancreatitis, and so this is the most common cause of abuse-related fatalities in toddlers. So the way we work these up for head injuries, we do a stat CT head and ophthalmology consult to look for those retinal hemorrhages. Other serious injuries with the abdomen, we get the LFTs, the lipase, urinalysis, and we might even consider a CT if we're worried about other injuries or liver lag. If the LFTs are greater than 80, it's a sign of occult liver injury. Children less than 2 with suspected child abuse should get skeletal survey radiographs, just because we don't know where in the body they could have had the trauma. So sexual abuse we see in families with other problems, also comorbid with physical abuse, domestic violence, and drug abuse. There's a lot of clinical manifestations with behavioral issues. So you might, if you notice excessive masturbation, inappropriate sex behaviors, or poor school performance, concentration, anxiety, and even suicidal ideations. These are pretty common presentations and pretty common manifestations. Some actual physical findings, you might not see these unless they're very acute, but you can have the genital lacerations, anal fissures, including, and pregnancy, anorexia, abdominal pain, dysuria, or vaginal discharge, especially if there's any concern for STDs. So we manage with a thorough history and physical with forensic or nursing specialists. And for our interns, when we see this a lot in these essays, the sexual abuse cases, and in the ER, we usually only handle the medical side of things. We like to leave all the sexual abuse history and sexual abuse examination to our SANE nurses because they're the experts on that. And they know the right questions to ask and the proper examination to do. We don't like to do that because it muddies the story and can interfere with the examination. So we usually let them handle a lot of those things and just focus on medical problems that they have with their abuse. So a lot of these victims will actually have normal findings. Sometimes they have shallow injuries like lacerations or hematomas, which may be accidental. But if there's penetrating traumas, then that's more likely for abuse. You want to consider and offer STD testing depending on the risk factors and the history that you're getting. All right, that's it. So we have our next review tomorrow from 1 to 4 over some of the subspecialties. And I think we're kind of out of, we use them almost all the time. It's like 3:40. So do you want to just save your part for tomorrow?
Yeah, but people are probably pretty tired.
Yeah. This took a lot longer. I thought we were actually going to finish a good bit early, but then the last few sections took a long time. Yeah. Yeah, thank you all so much. If I don't see you again in the next reviews, if I don't see you again in the next reviews, good luck in the IT. I'm really flattered that interns actually came out to these things because I usually don't think of interns studying for ITEs, but I think it's great. I think you should study for ITEs and begin and start working on getting your score higher every year. I think that's fantastic. I'm going to send out the video and the slides to everyone. And if I don't see you in the next reviews, what y'all can do to help, I'll send out like a thing for errata. That way when you're going through slides, or if you're going through like your studies and you find something in the slides that's wrong, any typos, anything that needs improvement or more pictures, if you could just let me know. There should be a form to fill out, or you could just let me personally know. I'm going to work on improving this every year we do it, so it just gets better and better. This year, I think the slides are a little crude in some places, and some of the facts may not be 100%, so that's why I want to work on it every year and getting it better. And also, when you take your ITE, if there's something that was on there that was not covered in the slides, if you want to let me know that, really low-key, because we shouldn't be talking about ITE questions, but low-key, if you just want to, the chiefs aren't here so I can say this, if you just want to tell me that, hey, this was an ITE and it wasn't in a review. Yeah, it's okay. Yeah, that would be really helpful too, so I can include it.